Hello, all. Very warm welcome to the Knowmics session on the Doctor of the Future, the whole genome sequencing interpretation course. We are glad to have all of you here. We will start with the speaker introductions now. We have with us Ms. Ramya Venkatesha. Ms. Ramya Venkatesha is a skilled and detail-oriented bioinformatician at Karkinos Healthcare, specializing in germline whole genome sequencing, clinical reporting. She holds a bachelor's degree in biotechnology from Bengaluru University and a master's in bioinformatics from the Manipal Academy of Higher Education. Prior to joining Karkinos, she completed a research internship at the prestigious Indian Institute of Science, Bangalore, where she further honed her analytical skills. At Karkinos, Ramya plays a key role in the germline reporting team, contributing to high quality clinical interpretation and variant curation workflows. Known for her creativity, precision, and sharp eye for detail, she excels at identifying clinically relevant variants in accordance with ACMG AMP guidelines. Her contributions are instrumental in ensuring accurate, clinically actionable reports that impact patient care. Ramya's passionate for genomics, combined with her technical rigor, makes her a valuable asset to the clinical genomics ecosystem. Further up, we have Dr. Bani Jolly with us. Dr. Bani Jolly is the section head of research and development in genome informatics at Karkinos Healthcare, specializing in genome informatics and translational genomics. In her work, she integrates informatics and genomics to advance our understanding of infectious diseases and inherited disorders with a focus on germline variant interpretation and whole genome sequencing. She played a pivotal role in shaping India's SARS-CoV-2 genomic surveillance, working closely with the World Health Organization to strengthen outbreak response capacities across Southeast Asia. Dr. Jolly has led the development of the widely adopted GenePy Box toolkit, empowering global researchers in outbreak analytics. Beyond infectious disease genomics, she has contributed to landmark NGS projects, including Indigen, India's first 1000 genome initiative, and Guardian, India's largest clinical genomic rare disease network. A PhD in computational biology from CSIR IGIB, she has over 30 peer reviewed publications and is a recipient of the Bird Award and regularly contributes to science communication pieces in the Hindu. It is wonderful to have our speakers here, and it is awesome to see all of you cheering on a Sunday morning for the session. Now I hand over the stage to Ms. Ramya Venkatesha to proceed ahead with the session.
Thank you, Harish, for such a wonderful introduction. Uh, so, good morning, everyone. So, let us begin with our first session on what and why of WGS, that is, whole genome sequencing. So, in this session, we'll explore how genetic testing has evolved, what WGS really means, and why it is rapidly becoming a foundational clinical tool. By the end of this talk, my goal is simple. I want you to see WGS not as a lab test but as a clinical strategy, something that changes how diagnosis, treatment, and prevention will look like in the future. So, let us begin with the basics. So, genetic testing is essentially DNA analysis, but that definition is too simple. So, in clinical practice, genetic testing is the process of reading variations in a patient's genome. So, you can think of the genome like a 3 billion letter book that describes how your body should function. A genetic test tries to find the spelling errors, missing paragraphs, duplicated chapters, or punctuation mistakes in that book. So these tests can help us answer questions like, why does this child have developmental delay? Why does this cancer behave aggressively? Which drug is the safest for the patient? Is the disease inherited? Is there a predisposition we should be alert about? So, genetic testing plays a very crucial role in modern healthcare, providing us with powerful tools to analyze DNA and identify changes in the genes or chromosomes. So, there are several types of genetic testing, each designed to detect different kinds of genetic variations. So, these tests operate at various levels of analysis: microscopic, submicroscopic, and DNA sequencing. So, at microscopic level, you have cytogenetic testing, which looks at large scale changes in the genome, in the chromosomes, changes that are visible under the microscope. So, one of the most common tests at this level is karyotyping, which can help detect conditions like trisomy 21, also known as Down syndrome. At the submicroscopic level, we use tests like FISH, that is fluorescent in situ hybridization, and arrays to detect smaller chromosomal changes such as copy number variations, which can be too small to see under a microscope. One example of a condition that is caused by a CNV is DJORD syndrome. Finally, at the DNA sequencing level, we perform molecular genetic testing. This technique goes deep into the nucleotide sequence of DNA to detect small mutations like point mutations, insertions, deletions that may not be visible through other methods. So, DNA sequencing can reveal mutations in genes like BRCA1 or BRCA2. This is one of the examples. So each level of genetic testing provides crucial information about genetic conditions, from large chromosomal changes to the tiniest mutations in the DNA sequence. Genetic testing offers a wide range of applications across different stages of life, helping individuals make informed health decisions. So, if we have to explore the key areas where genetic testing makes an impact, one would be couple screening that allows partners to understand their genetic compatibility, particularly when planning a family. Next would be newborn screening, which is a standard practice in many countries where babies are tested for genetic conditions shortly after birth. So these can be conditions like metabolic disorders or identifying conditions that require immediate treatment. Pharmacogenomics is another key application where genetic testing helps predict how an individual will respond to certain medications. Prenatal testing helps detect potential genetic abnormalities in a developing fetus. So, this can provide expectant parents with vital information regarding conditions like Down syndrome or other chromosomal abnormalities. Carrier screening is useful for individuals who may not have a genetic condition themselves but are carriers of the gene associated with certain diseases, something like cystic fibrosis or sickle cell anemia, often before or during pregnancy planning. Lastly, genetic testing for clinical indication is used when there is a suspicion of genetic disorders based on the patient's symptoms. Coming to what targeted sequencing panels are, so these focus on specific genes or gene sets that are clinically relevant to the condition that is being tested. So these targeting panels cover only a small portion of our genome, 0.01 to about 2% of the genome. So panels are like checking only specific pages of that 3 billion letter book that we have. These panels are designed to detect a range of genetic alterations like point mutations, small indels, very few copy number variations, and maybe some gene fusions. By honing in these specific areas of the genome, targeted panels provide a highly efficient and cost effective way, but panels here have a caveat. Panels work wonderfully when you already know what the gene is to look at. But medicine is not always that predictable. So rare diseases often have involve unexpected genes. Cancer evolves, phenotypes vary. The biggest limitation that panels miss are unexpected genes, non-coding variants, structural variants, regulatory region variants, complex rearrangements. So while panels have a high specificity, they lack breadth. Coming to our next type, that is whole exome sequencing. Again, it's a very widely used genomic testing method where we sequence the protein coding regions. And this exons make about 1 to 2% of our genome. So these are where the majorly known disease causing mutations occur. So WES detects single nucleotide variants, small indels, and very few structural variations. But again, here's the thing, WES still misses 98% of the genome, including regulatory regions, introns, deep splicing changes, structural variants, repeat expansions, mitochondrial genome, etc. Also, WES coverage can be uneven. Some exons are captured poorly, so WES is powerful but not complete. If the mutation lies outside of the exome, which is true for a significant percentage of complex diseases, WES cannot detect it. So, here is where WGS fills in the gap. Whole genome sequencing is the most comprehensive method for analyzing the genome. Unlike targeted sequencing, which examines only a specific portion of the genome, WGS sequences almost every base in our DNA, offering us a complete view of a person's genetic makeup. So, by sequencing the entire genome, WGS captures all genetic variations, including those found in both coding and non coding regions. This is important. While targeted sequencing focuses on only known genes, WGS can give us insights into regions of the genome that play a significant role in diseases, even if they are not a part of the protein coding regions. So, some of the things WGS detects are chromosomal abnormalities, structural variants, repeat expansions, deletions, indels, single nucleotide variants, as well as mitochondrial DNA. So now let's pause and take a look at the slide. Starting from the right, array genotyping. It is the most focused and limited in scope. As mentioned, it covers about 0.01 to 0.05% of our genome. So it's targeting very known and frequent variants that have already been well characterized. So while this is cost effective and can quickly confirm common genetic variations, its clinical utility and discovery potential are minimal. So, this method is not designed for uncovering new or rare variants, but it's useful when clinicians are probably looking for specific or well known genetic markers. Coming to whole exome sequencing. So, this is a slightly more broader approach where we are analyzing 1 to 2% of the genome and we are only focusing on the exons, that is, the protein coding regions. But finally, the whole genome sequencing, in this case, it is the most comprehensive option because it's covering all the bases of the genome. It includes both coding, non coding regions, giving it the highest potential for discovery and clinical applicability. So, WGS offers robust coverage, makes it ideal for identifying both common and rare genetic variants, including those that may have been missed by more targeted methods. So, if you see the bottom of the slide, you can see how these three methods compare in terms of their utility. So, array genotyping is limited to known variants and has the smallest discovery potential. WES is a step up, focusing on coding regions, but it still pales in comparison to the WGS, which provides the broadest and deepest coverage, offering the greatest potential in terms of both clinical and research discoveries. So, whole genome testing can replace multiple traditional genetic tests with a simple, comprehensive solution. So, WGS covers all the major types of genetic tests that are offered currently in the market. Like, for example, chromosomal abnormalities uses techniques like karyotyping or fluorescence in situ hybridization and ACGH. All these methods are used. For structural variants, we again use techniques like FISH, ACGH, or multiplex ligation dependent probe amplification, that is MLPA. But again, these tests take 2 weeks or more and may not capture all types of these structural changes effectively. For detecting repeat expansions, We have repeat primed PCR that is employed, or even for deletions, insertions that are small indels, again MLPA may be used. Lastly, for our single nucleotide variants, that require methods like capillary sequencing or panel sequencing, so WES may be used. Again, these may take about 2 to 4 weeks for completion and may still miss some important non coding variants or structural changes. So, each of these tests obviously have a specific focus and require its resources, infrastructure, and time to complete. And this fragmented approach may delay diagnosis and treatment, especially when multiple tests are needed to capture the full picture of a patient's profile. But WGS, on the other hand, eliminates the need of this multi step process because by sequencing the entire genome, it covers all the genetic variants in just one test. So, some of the advantages of a whole genome sequencing. So, here we can start with pharmacogenomics, where WGS can identify 306 variant or haplotype drug combinations in 29 genes. Of these, 59 are oncology related variants in 7 genes are directly linked to cancer therapies. Beyond pharmacogenomics, WGS also gives us some secondary findings. That is because of, according to ACMG secondary findings, that is version 3.2, WGS can identify pathogenic or likely pathogenic germline variants in 81 genes that encompass over 90 disorders. This also includes 28 genes associated with 19 different cancers. Lastly, WGS provides insights into germline predisposition. So, by detecting pathogenic or likely pathogenic germline variants in cancer predisposing genes, it can help alert individuals to a heightened risk of hereditary cancer. So, the genome is clinically relevant in every stage of life, and whole genome sequencing provides a single data set that retains value across the entire lifespan. So, unlike other diagnostic tests which answer only one question at one point in time, the genome remains from the same from birth to old age. But different parts of it become clinically meaningful at different moments. So, starting at birth, genomic insights are immediately life saving because many newborns with metabolic disorders or primary immunodeficiencies deteriorate rapidly without early detection. As a child grows, their genome helps explain neurodevelopmental conditions such as autism, spectrum disorders, intellectual disabilities, some neuromuscular disorders, and maybe some pediatric cancers. In adulthood, new genomic questions arise. This is when cancer predisposition genes like BRCA1, 2, or TP53 or Lynch syndrome genes become more clinically actionable. In later decades, the same genomic dataset informs risk of late onset neurodegeneration such as Alzheimer's, Parkinson's disease, maybe some hematological malignancies, and cardiovascular disorders. Even transplant matching and immune compatibility can reflect some genetic information. So, the significance of the genome evolves with age, but the data does not have to be recollected. WGS gives us a one time, lifelong foundation for decision making. Coming to diagnostic positivity, we can see here a study from Canada highlights the highest higher diagnostic yield offered by WGS compared to conventional genetic testing. So, this study involved 103 patients from pediatric clinics, out of which 24% obtained a diagnosis through conventional genetic testing methods. However, when WGS was used, the diagnostic yield increased significantly, with 41% of the patients receiving a definitive diagnosis. Another major piece of evidence supporting WGS comes from a large multi center study that evaluated how many families actually receive a diagnosis when germline sequencing is used as a part of clinical care. So, this study included 822 families, 744 in the main cohort, and 78 in an independent replication cohort, all of whom had children with suspected genetic disorders, and the overall diagnostic yield across these families was 29.3%. What's particularly important is that 8.2% of these families had variants that could not have been detected by conventional genetic methods. So, when we talk about implementing WGS in clinical practice, one of the most common concerns is cost. Historically, genome sequencing has been considered very expensive, and that perception still lingers. But healthcare economics show a very different reality. So, here is an infographic to understand a study from 2025 that explains the willingness to pay and cost effectiveness data across different high impact clinical scenarios. So, in disorders like childhood rare diseases, acute neurological presentations, or newborn ICU cases, the cost of prolonged hospitalization, ineffective treatments, repeated imaging, and multiple rounds of genetic testing actually far exceeds the cost of performing a WGS upfront. So, using a single comprehensive test, because we don't have a multi step test that is required, because WGS collapses the entire diagnostic pathway into a single comprehensive test. As the cost of sequencing has plummeted, the number of genomes sequencing has surged. More genomes are being analyzed than ever before, and this has led to an exponential growth in the number of human genetic variants reported in research databases like PubMed. This increasing volume of data has provided a much richer understanding of human genetics, helping us to identify the diseases. Looking ahead, WGS is poised to replace WES and other targeted panels for clinical diagnosis as a preferred method. So it provides a more comprehensive view and is going to become affordable for clinical workups. So by 2030, it is expected that genome sequencing will become a routine part of personalized medicine. So WGS directly benefits from clinical practice when whether you have a precise molecular diagnosis by not just naming a disease, you're rapidly narrowing the management path. It helps us avoid unnecessary tests, reduces time spent on differential diagnosis, and moves quickly towards targeted therapies or appropriate supportive care. So, whole genome sequencing is no longer just a research tool, it is becoming the new clinical standard. It brings together every level of genomic information in a single test, reducing diagnostic uncertainty and eliminating delays from multiple rounds of testing. By providing faster answers and greater diagnostic yield, WGS enables us to initiate appropriate interventions sooner, and it helps avoid unnecessary treatment and deliver more personalized care for our patients. Ultimately, WGS helps us move from reacting to disease to truly anticipating and preventing it. And that is what precision medicine is all about: the right diagnosis, the right treatment at the right time for every patient. So, I would like to conclude by driving home this very strong but important message: from womb to tomb, WGS has you covered. Up next, we have what is in a WGS clinical report by Dr. Bani Jolly.
Thank you, Ramya, for that insightful session on the why and the what of WGS, and thank you for the handover. Hello, everyone. Now I'll be presenting to you what exactly do you expect out of a GS report. Right, so welcome to this session where we will now shift from who exactly needs a whole genome sequencing test to a very natural question that what can your WGS test actually tell you? And many people still think of genome sequencing as something that gives you a yes or no diagnosis for a rare disease, but its power actually goes very, very far beyond that. WGS is now one of the few tools in medicine that can give us a complete single shot view of somebody's genetic makeup, which includes large chromosomal changes to the smallest nucleotide variant from mitochondrial DNA to pharmacogenomic findings. This can include inherited risk, acquired findings, and everything. So, in this session, we'll we'll explore what exactly does this mean. What we look at the kinds of variants WGS can detect, how it can capture the entire landscape of the genome, and how these findings can translate into actionable insights. And not just for rare disease, but for example, cancer risk, cardiac risk, drug response, newborn health, and even proactive screening in healthy individuals. So by the end of the session, you'll see that WGS doesn't just tell you one thing, it can tell you almost everything that genetics has to offer in a single test. So let's dive into what all can a WGS report tell you. So what exactly does a WGS report include or can include? At a very high level, it spans across several different categories. So first, we have clinically relevant germline variants, which are actually pathogenic or likely pathogenic variations that can help explain the phenotype or the disorder of the patient that we are looking at. Then we come to carrier status variants, which may not affect the individual but can be relevant for family planning. Then we have pharmacogenomic markers which can guide drug dosing and safety for a particular patient or a person. We have structural variants that can be uncovered using whole genome sequencing, which includes deletions, duplications, and rearrangements that can explain a disease. And we have mitochondrial variants, which are especially important in cases of suspected mitochondrial disease that overlap a lot of symptoms. And then, of course, we have the second category here, which is the secondary findings or incidental findings, which can be reported as per ACMG recommendations. And all of this is embedded into a single comprehensive report. And let's walk through how each of these components get evaluated. So, coming to first, the most important one, which is the phenotype driven or the clinically relevant germline variants. These are actually the cornerstone of the most diagnostic WGS efforts, because here we are looking for variants in genes that match the patient's phenotype and explain the disorder, especially those classified as pathogenic or likely pathogenic under the ACMG guidelines. But also remember that interpretation is not just about the variant, it should also fit the clinical symptoms, inheritance pattern, zygosity, and segregation data if available. So often this section is meant to answer the primary clinical question and forms the basis of further medical management for a particular patient. So let's break this all down in detail with an example, because it brings together multiple concepts that are very key to interpreting a WGS report. First, you will see coverage, which is 32x. It means that the genomic position where the variant was found was read 32 times by the sequencing machine. And that's a strong number when it comes to whole genome sequencing, because it gives us high confidence that the variant call is actually accurate. Low coverage might make us question whether a variant is real or not. Next is the zygosity, and in this case, it mentions it as heterozygous. So, this tells us that only one of the two copies of the gene in this particular patient carries this variant. And this is now important when we think about the inheritance pattern of a particular disorder. So, in this case, the condition that we have associated this gene with is called Timothy syndrome, and it follows an autosomal dominant inheritance pattern, which means that just one faulty copy is enough to cause disease in this particular patient, which aligns with the heterozygous status of the variant that we have detected. So now if we look at the Omium table, it links this gene to actually multiple conditions, including long QT syndrome, Timothy syndrome, and these are all associated with certain neurological, cardiac, and developmental symptoms. And here is the clincher of all of it. The patient's clinical features, for example, things like global developmental delay, encephalopathy, dysmorphism, line up very well with the expected phenotype for Timothy syndrome also. So, this clinical match combined with the zygosity, inheritance, and coverage supports why this variant is labeled as likely pathogenic. And so, in summary, the coverage of a particular variant positions tells us how trustworthy the data is. Sorry. Zygosity tells us how many copies of the person's DNA carry the variant. Is it just mutated in one of the DNA copies, or is it mutated in both? The inheritance model helps us interpret what is the disease risk for this particular patient, and the phenotype match then helps us decide whether this variant truly explains the condition or not. And now, because we are talking about whole genome sequencing, this goes beyond single nucleotide variants, as it also gives us access to structural variants, especially large deletions and duplications, which can also be called as copy number variations or CNVs. So these can be pathogenic gains or losses involving one or more genes, and they are especially important in neurodevelopmental disorders and syndromes, and also for some forms of cancer. So, in a WGS report, these will be usually placed under the primary or the significant findings if they are clearly linked to the phenotype of the patient that we are looking at. And the key reporting fields for CNVs or SVs include whether it's a deletion or a duplication, the exact genomic coordinates and the cytoband location of this particular change, the genes that were affected, the zygosity, whether it is a heterozygous loss or a homozygous loss, for example, the associated disorders according to the genes that were covered in that particular structural or copy number variation, and the inheritance model of all these genes, all these disorders, and of course the clinical classification that can be interpreted by looking at the patient, by looking at this variation and correlating it appropriately. So, whole genome sequencing can actually detect even small exonic copy number variations that traditional tests actually miss quite often. So, it makes it a very critical advantage for whole genome sequencing when it comes to clinical diagnostics. And for example, this case shows how whole genome sequencing can detect pathogenic structural variations that can be missed on routine sequencing with either panels or, for example, whole exome sequencing. So, for example, here we have a 1 month old male who presented with microcephaly and brachycephaly, thin upper lip vermilion, and global developmental delay. The whole genome sequencing test was done for this particular patient, and the report identified a heterozygous deletion on chromosome 22, spanning approximately 3.7 kilobases located at cytoband 22q11.2. Now, this region is something that includes a gene called TBX1, which is very well known to be associated with the George syndrome, which is an autosomal dominant disorder. And based on the phenotype of the patient actually matches the reported phenotypes for this particular syndrome. So, based on the phenotype of the patient, the gene that is involved, and the known pathogenicity of this deletion, this copy number variation can be reported as pathogenic or as likely to be causing the disease in this particular patient. And now we see the exact genomic coordinates spanning chromosome 22, 19,700,000 something, covering approximately 3,000 base pairs in the 22q11.2 region. This deletion overlaps the TBX1 gene, which is confirmed here via the genome browser screenshot that you can see on this slide. Clinically, this deletion aligns with DiGeorge syndrome as listed in Omium, with a matching MIM number, autosomal dominant inheritance, and a direct correlation with TBX1. So, the combination of genomic mapping, phenotype correlation, and literature backed gene disease relationship allows this deletion to be confidently reported as pathogenic. And this kind of layered evidence from sequence to phenotype to databases is what gives WGS its diagnostic and its academic power into actually realizing and uncovering a lot more things that traditional tests fail to do. Coming to the second important thing in a whole genome sequencing report, which is the incidental and actionable genetic findings or the secondary findings. So, these are results that are not really related to the reason for testing but are still important to report because they can offer actionable medical insights for the patient. For example, finding a BRCA1 mutation for someone who underwent a whole genome sequencing test for a neurological condition can be considered as an incidental or a secondary finding. So the ACMG has curated a list of such genes. Currently, it includes 84 genes in version 3.3 that covers 52 unique disorders across four different phenotype categories, which includes hereditary cancers, cardiomyopathies, arrhythmias, and metabolic conditions. So the principle here is that if a variant is in one of these genes and is classified as pathogenic or likely pathogenic according to ACMG AMP guidelines, it must be reported because early intervention in these list of disorders could actually save lives, even if the patient is or the person is currently healthy. And this is one of the biggest strengths of WGS, the ability to find unexpected results and still make it very, very clinically meaningful. So let's break down what qualifies as a secondary finding in a whole genome sequencing report. These are variants in a curated list of genes defined by ACMG. Version 3.3 is the current list that we have. And these genes have a established clinical guideline for intervention and follow-up. So, crucially, these findings are unrelated to the clinical reason for ordering the sequencing, and thus, this usually appear in a section or in a header titled Secondary Findings. The reporting of these variants will be formatted something just like the primary variants, though. So, for example, if we take this case, so the goal here is to actually give the patients and their families clinically meaningful, actionable health information, even if it is not immediately relevant to the current diagnosis. So, if you look at this real world example of a secondary finding that is very clinically important to a particular person, so we have a healthy 35-year-old woman who underwent whole genome sequencing for a very unrelated reason. But the test identified a frameshift deletion in the BRCA1 gene, which leads to a premature stop codon and is reported as heterozygous. So whole genome sequencing detected this heterozygous variation in BRCA1 gene. And the variant has a good coverage at this particular position, which is 35x. The variant is classified as pathogenic, supported by appropriate ACMG attributes, including attributes like PM2, PBS1, PP5, which indicates that the variant is rare. It causes loss of function of that gene, and it has a prior clinical association that has already been known. And we know that BRCA1 is associated with hereditary breast and ovarian cancer syndrome, which is an autosomal dominant condition. And now, even though this finding wasn't related to the original clinical concern, it is still medically very, very significant because it gives or it enables early screening, surveillance, and even preventive strategies in this particular patient now. And this is why secondary findings are or should be reported, because sometimes the most important result is not actually the one that you were looking for. And we will discuss more in detail about this later on in our slides. And coming to other incidental germline findings, so these are findings that don't really fall under the category of ACMG secondary findings list, but they still might have some clinical relevance. So they are typically classified. They are typically classified as likely pathogenic or pathogenic, and might act as risk modifier or be associated with future disease risk for some disorders. So they might appear in a separate section in the report labeled as other germline findings, and the structure of reporting will be similar to the other primary and incidental finding variants. So, for example, we have a healthy 28-year-old male who has a missense variant in a gene called Notch3, and which is a gene associated with a condition called CADASIL, which is an autosomal dominant disorder. Now, the reason for testing for this patient or this person also was something very, very different, but this is something that has been additionally detected. And the variant that we have found is also classified as pathogenic according to ACMG AMP criteria. And even though this person is now asymptomatic, this detection or this the variant that we have detected in this patient could inform future neurological surveillance or also family screening for this particular person now. And such findings actually walk a very fine line because they are not immediately actionable but may impact long term care. So, if in case you're sending in a patient or a person for a whole genome sequencing report, you can also optionally include all of these findings depending on whether they want to know these findings or not. Coming to the next important thing, which is clinically actionable pharmacogenomics variants. So, pharmacogenomics is a very powerful application of whole genome sequencing because it helps predict how a person will respond to medications and then can thus guide drug choice, dosage, and risk management for them. And these drugs can include, or these findings can include categories that can be something like identifying individuals that are at a high risk for adverse drug reactions, variants that increase the risk of causing an adverse drug reaction to a particular drug because of a particular variation that the person has. It can inform dosage and efficacy adjustments like needing a lower dose or predicting no response to a particular drug. And it can inform the metabolism type for a particular patient or a person. So, for example, are they a ultra rapid metabolizer or are they a poor metabolizer for a particular drug? So, for example, a DPYD poor metabolizer can be flagged before 5-FU chemotherapy can be administered in that patient, enabling the clinician to proactively modify the treatment plan for that patient now. And that's real time precision medicine in action, and all of this can be included in the same test report that we prescribe for a patient or a person. So, for example, here is how a pharmacogenomics report may look like in a WGS report, and this one is for DPYD gene that determines how safely a person can receive 5-fluorouracil, which is a very commonly used chemotherapy drug. So, in this case, the patient has a homozygous no function genotype, which dramatically increases the risk of severe or even life threatening toxicity if administered 5-fluorouracil. So, a clinical consortium that curates pharmacogenomics variants, which is called as CPIC, classifies this as a 1A clinical action level, meaning that the evidence is very strong and the clinician must adjust treatment according to this germline finding in this patient. So, a very simple genetic variant in one single gene, something you'd never know about without testing, can completely change drug choice, dose, and monitoring for a patient. And this is a perfect example of how WGS can, using the same single report and data, impact real world treatment decisions for a patient. And then we come to carrier status for certain Mendelian genetic disorders. And this is an example for it, something whole genome sequencing can detect even in completely healthy individuals. So here we have a healthy 30-year-old woman who went in for sequencing just because she was curious about her health. And they found that she carries a pathogenic variation in a gene called as CFTR, which is associated with cystic fibrosis, which is an autosomal recessive condition. And now notice that the disease is autosomal recessive while the variant detected in her is in a heterozygous state, meaning that only one copy of her gene on her DNA holds this variation. So she will never develop the disease herself, but this information becomes extremely important for family planning. Because if a partner is also a carrier, there is a 25% chance of the child being affected by cystic fibrosis. So, whole genome sequencing captures the exact variant, zygosity, and evidence level and the classification for it. So, your report can give clinicians and families very clear and actionable information long before pregnancy or newborn screening. So, this is a perfect example of genomics that can enable proactive, informed reproductive choices for healthy people. And coming to the last thing, which is mitochondrial DNA variations. And now let's take a moment to actually understand what are mitochondrial DNA variations and what is mitochondrial DNA and how it may be interpreted in a whole genome sequencing report. So, unlike our DNA in our chromosomes, the mitochondrial DNA is a small circular genome found exclusively inside the mitochondria, which we all know as the powerhouse of our cells. So each cell contains hundreds to thousands of mitochondria, and each of these mitochondrion has several copies of its own genome or own DNA. So this mitochondrial DNA is inherited almost exclusively from the mother, which makes its inheritance pattern quite distinct compared to other germline variants that we see. And now disorders caused by mitochondrial DNA variants often affect organs that have a very high energy demand, like the brain, muscles, heart, and eyes. So, whole genome sequencing is something that allows us to sequence the mitochondrial genome along with the nuclear genome because of its unbiased nature. And but what's unique here is the concept of heteroplasmy and homoplasmy, which we will also go through in our further slides. So, the heteroplasmy and homoplasmy levels matter in cases of mitochondrial DNA variations because symptoms often appear only when a large proportion of mutated mitochondria are present in a patient, which is called as the disease threshold. So, below that, a person may remain asymptomatic or have very mild symptoms. Understanding this threshold effect is actually very key to interpreting mitochondrial disorders because it affects how severely and whether a variant will manifest clinically. So, when reporting mitochondrial DNA findings in our reports, we should include the gene and the variant that were detected, whether the variant is homoplasmic or heteroplasmic, the heteroplasmy level as a percentage, and then, of course, the classification and the associated disorder with that variant. So these findings may be very, very rare but critical, especially in cases that in which metabolic, neuromuscular, and multisystemic symptoms are seen in one single patient. So here is a clinical example of a mitochondrial finding. We have a 3-month-old male who presents with very severe symptoms, including sensory neural hearing loss, optic atrophy, lactic acidosis, seizures, and dystonia. So the multi-systemic involvement already leads us to suspect a mitochondrial disorder. The patient was sent in for a whole genome sequencing, which revealed that a variant in the MTTV, which is a mitochondrial tRNA gene, was detected. The variant was detected in a homoplasmic state, meaning that all copies of mitochondrial DNA in that patient carry that mutation, with 100% heteroplasmy detected at a high coverage of 388x. So, this variant or this gene actually matches with a condition known as Leigh syndrome, which is a very severe mitochondrial disorder affecting metabolism, affecting your eyes, affecting your neurodevelopment, and a lot of other functions of the body. And the variant is classified as likely pathogenic, and this diagnosis would have been very difficult to achieve without a whole genome sequencing test, particularly because mitochondrial DNA isn't captured in standard exome sequencing assays. So, this finding enables not just diagnosis but appropriate genetic counseling for the family also now, keeping in mind that mitochondrial disorders follow maternal inheritance. So, in summary, the whole genome sequencing test reports may start with phenotype driven findings, which are usually the diagnostic anchors. The whole genome sequencing test might look for secondary findings, which can offer preventive value even outside the presenting complaint. The report may include pharmacogenomics to tailor drug treatments for the patient, all included in one single test report. It can also report carrier status that can be used for reproductive planning. And most importantly, it does not ignore mitochondrial or structural variations, especially in syndromic or multisystemic cases. And thus, you should always check for QC metrics in a whole genome sequencing report before you actually begin interpreting whether the variation can be linked to the disorder that the patient is presenting with. So, in short, whole genome sequencing is not just comprehensive, it is future ready because it gives all this information in one single unified report. So, with that, we'll stop here and we'll take up questions for these two sessions about the what and the why of whole genome sequencing. So, please feel free to post your questions onto the chat box.
Hey, hi, Dr. Bani. There is already a lot of questions that is coming in through the YouTube comment section. If you want, you can, the viewers, if you want, you can also post your questions there. So I'll get started with a few of the questions in the YouTube comment section. Okay. The first one is, can WGS replace karyotyping as well?
Yes, absolutely. WGS can very well detect copy number variations and large deletions or duplications at the chromosomal level at a very good resolution. So, yes, it is one test that can not only give you karyotype answers, it can look for smaller CNVs that are something that are missed by karyotypes, and it can also give you if any single nucleotide or a smaller variation is present in that patient or not. So yes, one single test can include karyotypes, it can include smaller deletions and duplications and the smaller variations if in case they are present.
That's awesome. I guess the user smart 9924 got their answer. The next one is again from the same person. The question is, in OMM, there are a few disorders that have both AR and AD stated. So I don't understand how. So this is their question.
Right. So Omium basically curates information that comes in from multiple reports across anywhere in the world. And a disorder may initially begin as autosomal recessive because people across the world have seen that only homozygous patients have manifested those symptoms. But in the future, some doctors might see patients who have a heterozygous status of the same variation that has been already known to be pathogenic, but now they also present with the disease even though they are not homozygous for it. So the disorder may also be now classified as autosomal dominant. So depending on what all reports start coming out from anywhere in the world, the more people we sequence, the more studies we perform by these genomics tools that are now getting integrated into clinical workups, the inheritance patterns may actually be updated in databases like no, like Omium.
Okay, that's a really great response. Thanks, Dr. Bani. And also another question from Kumar Paras. What is the difference in using long reads and short reads for WGS? So this is again a pretty advanced question here, but yeah, let's try to simplify and answer, Dr. Bani.
Right. So long read sequencing, short read sequencing are actually two different technologies that are currently available for whole genome sequencing. Now, both of them have their own advantages and disadvantages. Short read sequencing, all in all, is much more accurate because the resolution at which the variants are captured and the accuracy and the quality of the variations is much, much better compared to long read sequencing. But long read sequencing, because of the inherent nature of them, have the advantage that certain large regions of the genome that are a bit difficult to resolve using short read sequencing are much better captured here. So, for example, repeat regions are something that can be resolved better using long read sequencing, and things such as very large structural variations may have a better resolution using long read sequencing. And now, because now we have PacBio machines in the world, so using that, we can actually sequence a genome telomere to telomere, which is something that the Illumina chemistry right now does not include. So, all in all, short read sequencing, go for it whenever you need a higher resolution for and high quality for different kinds of variations. And if you suspect something that may include repeat rich regions, it is better to go for a long read sequencing. So, both are good because both carry very mutually exclusive advantages of their own.
Okay, that's really good to know. So again, a few more questions here. So this is on how do we communicate the incidental finding to the patient when they haven't asked for it? This is again a question that is in the minds of more clinicians.
Right, absolutely. So the problem with incidental finding is that a lot of people may not want them to be reported depending on what they might deem as something that is useful or might increase anxiety is what the perception is, what the perception is currently held by a lot of people. So yes, it makes sense to ask your patient or the person whom you are referring for whole genome sequencing whether they would like to know about their incidental findings or not. If they choose not to know, then it makes sense not to report. But in our experience, whenever we have asked people if they want to know their incidental findings, they usually say yes. Actually, 99% of the time they have said yes, because if they are going in for a report that is so future proof, they want to know everything out of it. But for cases, for example, pediatrics, it is actually the doctors and the patient families call whether they want to know these findings or not, as they might cause unrelated anxiety in the family. So yes, always ask. And if the answer to that question is yes, then always feel free to include all of these just to make sure that your patient has the full advantage of the test.
Okay, considering the time limitations, I'll just go with the last two questions, and that's about it. The remaining questions we will ensure to answer back on the chat boxes. So the second from the last question is that. So I have a doubt in WGS. How do we separate the nuclear genome from my genome?
How do we separate the nuclear genome from mitochondrial genome?
Yeah, mitochondrial genome. Yes.
Right. So that is not a problem that exists actually. It's something that is solved by the analysis. So mitochondrial DNA has a different reference genome to which your analysis and your mapping and alignment tools will map back to if the reads have been detected on the mitochondrial DNA. So the VCF file, which is the output of a whole genome sequencing or any kind of sequencing basically, will have those mitochondrial DNA variants present as annotated under chromosome M or CHRM or CHRMT in some cases. So anything that does not lie in CHRM in that VCF file is something that belongs to your nuclear DNA. And things or variations that belong specifically to your mitochondrial DNA will always be represented as a chromosome M variant in your VCF file.
Thanks a lot, Dr. Bani. The last question here is, how does WGS work for cancer diagnostics? The right question to the right organization, I can say here, with multiple small clones. How does WGS work for cancer diagnostics with multiple small clones? How can we manage to reach the kind of depth a targeted sequencing provide? Wouldn't it be a data management nightmare?
Okay, so whole genome sequencing, when I talk about the germline aspect of it, it can pick up variants that are linked to hereditary cancer syndromes much better than a whole exome sequencing test. So I'll give an example of, for example, the BRCA1, BRCA2 genes for which the standard clinical guideline for having for testing has always been whole exome sequencing plus an MLPA. Now, these are two different tests that will have two different turnaround times, two different interpretations, and two different things that a patient might have to go through. A whole genome sequencing test will not only give you the single nucleotide variations that are covered or the small variations that are covered in a whole exome sequencing. For BRCA1, BRCA2, for example, it will also give the deletions and duplications which are covered in a standard MLPA. Having said that, the whole genome sequencing will not just give you BRCA1, BRCA2 for a patient, it can also give you variations or deletions, duplications in other important genes that might be linked to hereditary breast and ovarian cancer syndromes. So, studies have actually found that a majority of the germline findings for breast cancer patients did not really lie in BRCA1, BRCA2 genes, but actually beyond those two genes in the other HRR related genes. And sometimes we have findings in genes that are related to other cancer syndromes and not really in the HRR genes also. So it makes sense that if you really want to screen a person for a germline variation linked to a hereditary cancer syndrome, go for a bigger test because it will not just tell you what is known in the limited knowledge base that is present in literature. It can help you give an exploratory feature far beyond it and actually cover all those things that might be responsible for that patient then.
Awesome, awesome. This is exciting. Thanks, Dr. Bani. Thanks a lot for your responses.
Right. So I think we can move on to the next session, and the remaining question we will be answering in the chat box itself.
Thank you all. Please post your remaining questions. If you have more on the chat box, uh, our team is very active and we would love to get back to you and give your responses over chat window there. Now, on to our next session.
Thanks, Harish. So let us begin with our session 3, where we will walk through the next W, that is when whole genome sequencing, that is WGS, should be recommended and how it is shaping the future of precision medicine. So we now live in a time where genomics is shifting healthcare from reactive to predictive. So here's the thing, every one of us carries millions of genetic variants. Most are harmless, but a few can significantly shape how our health unfolds over time. Some variants explain why a baby is born with a heart defect, maybe some predict whether a child will develop seizures, some tell us exactly what medications a patient can safely take. So, the challenge in clinical practice is that we often discover these insights too late after the damage has already occurred. That's why experts say the best time to sequence your genome was yesterday, and the next best time, today. Because the earlier we uncover these risks, the more time clinicians have to intervene, monitor, prevent, and guide care. So, if we ask the question, when is whole genome sequencing recommended? A better question might be, why do we have to wait at all? One of the clearest examples to show how earlier genomic insights can change clinical decisions is in carrier screening. So, many of the severe genetic conditions in children are inherited silently. So, parents appear completely healthy, but they can carry one faulty copy of a gene each. And when two carriers come together, suddenly a newborn can face a life threatening disorder that no one could have predicted. Recent studies show that 1 in 43 women carry a pathogenic variant with real implications for pregnancy or newborn health. So, when we usually think of carrier screening as something that impacts the baby, the mother's own safety and health are at risk too sometimes during the pregnancy. This is where WGS gives us a major advantage. So, instead of screening for a tiny set of genes, we're able to look at the entire genome to see if we are missing anything important. Of course, once a baby is born, we continue to rely on screening to protect them. But when we compare traditional newborn screening to genomic newborn screening, the difference is enormous. We know hundreds of serious childhood diseases that many are treatable, but they remain invisible to standard screening. So families only learn about them after the damage is already begun. So, genomic newborn screening completely changes that picture. With a single test, the same tiny blood spot, we can scan for a vastly broader range of conditions. Conditions for which early intervention could mean the difference between a healthy childhood and a long disability. So, imagine on the very first day of life, every child received not just a screening test, but a personalized lifelong health map. Now, what about babies who are already critically ill? The NICU is probably one of the most heartbreaking places in medicine, where we fight every second to understand what's happening inside these fragile newborns. This is where rapid whole genome sequencing has completely changed the game. So, in a recent study from Israel involving 130 critically ill neonates across 25 intensive care units, rapid WGS delivered a diagnosis in just 10 days and a more detailed report in 60 days. Now, here is the powerful part. The diagnostic positivity was 50%. That means half of these extremely sick babies finally received an answer that could guide on what to do next. And what's encouraging is that it isn't just an isolated success story. Hospitals worldwide are seeing the exact same benefit when rapid WGS is being brought to the bedside. Centers across the world, from the United States to Europe, are independently reaching the same conclusion that rapid whole genome sequencing improves outcomes and saves life. So, at Seattle's Children's Hospital, when WGS was offered to inpatients outside of NICU, for children who were sick but not critically ill, they received a diagnostic rate of over 42%. At Rady's Children's Hospital in San Diego, one of the pioneers of WGS, rapid WGS diagnosis, in as little as 48 hours helped doctors. Okay, so what about babies who appear completely healthy? Could genome sequencing still uncover hidden risks in them? The answer is yes. And Guardian study shows exactly why. So the Guardian study in United States enrolled 4,000 newborns and conducted genome sequencing alongside routine newborn screening. Here's what they found. So genome sequencing identified 120 babies, that is 3% of the population, with serious but treatable genetic conditions, but only 10 of those children would have been detected if they had gone for a standard newborn screening, which means that at least 110 families would have gone home completely unaware that a preventable medical crisis was waiting ahead. And this isn't only happening in individual hospitals or research studies. Entire nations are now moving towards genomic newborn screening. And one of the biggest examples is the NHS in United Kingdom. During the generation study, about 100,000 newborns will receive genomic sequencing. So the purpose was to detect over 200 rare onset but treatable conditions as early as possible. And the strongest support for WGS early comes from our clinical guidelines. So let's take a look at those. The American College of Medical Genetics and Genomics, that is ACMG, now recommends whole genome sequencing as the first line test in children with congenital anomalies, developmental delay, intellectual disability. So these are some very common indicators in pediatric genetics. The International Precision Health Partnership (IP chip) focuses on critically ill newborns, and they recommend whole genome sequencing as a first line test in NICU patients with unexplained hypotonia, which is one of the most frequent presentations of serious neuromuscular or metabolic diseases. The American Academy of Pediatrics include whole genome sequencing again for tier 1 testing for global development delay and intellectual disability. For individuals with unexplained epilepsy, the National Society of Genetic Counselors strongly recommend genetic testing, ideally whole genome sequencing as their first year test, because certain seizure disorders respond to very specific treatments, and in some cases, the wrong medication can actually worsen the symptoms as well. And these are not isolated opinions. European clinical guidelines align with the same approach to timing. The European Society of Human Genetics also supports early use of whole genome sequencing. Their guidance states that WGS should be introduced into diagnosis when it provides a clear improvement in diagnostic yield, quality of result, and efficiency of testing. Some professional organizations like AAP, AES, ACMG, all of these organizations that represent frontline clinicians who see the burden of delayed diagnosis are also recommending WGS. So this gives us a very clear message that WGS has moved from optional to essential in early genetic valuation. So, WGS is not only recommended in guidelines, it's already being rolled out across multiple real world programs. Projects like Baby Seek, NB Seek, Baby Beyond, Screen for Care, and the Guardian Initiative. On a national scale, the NHS Generation Study in England. So, all these initiatives are showing that WGS is actively being adopted in clinical settings, both in specialized hospitals and within public health systems. So, when a child has a rare genetic disorder, every day without a diagnosis increases the risk of irreversible harm. So, 1 in 3 critically ill infants with suspected genetic disease die before we find the answer. 30% of the children with a rare disease don't live past age 5. And families spend 5 to 7 years on a diagnostic journey that is emotionally and financially exhausting. WGS, that is whole genome sequencing, changes that timeline. It brings answers early enough for us to act, early enough to protect development, and lastly, early enough to save lives. Up next, we have Dr. Bani explaining the last W, that is, whom should the WGS be recommended to? Over to you, Bani.
Thanks again, Ramya. Right, so welcome to the last session so far, and now until now we've explored the what of whole genome sequencing, the why of whole genome sequencing, and the when of whole genome sequencing. So let's shift the question to something that every clinician and geneticist you eventually ask: that whom should we actually consider for a whole genome sequencing test? And in this session, I want to walk you through the kinds of clinical scenarios that we may see where whole genome sequencing truly changes the outcomes, and where this single test can collapse years of investigations into one very meaningful answer. But so by the end of this session, you will have a clear practical framework to decide when WGS is worth bringing into the conversation. So let's see who benefits the most from it and why. So let's start with the first very obvious group who should absolutely be considered for whole genome sequencing, which are patients with unsolved medical mysteries. So, when we talk about genetic disorders, the scale is actually very, very massive. Around 400 million people worldwide are living with a genetic condition. And if all of them actually were to form a single country and live in it, it would be larger than the United States of America, which stands at a population of 347 million people. And bringing this conversation closer to home, the estimates for India are around 70 million individuals suffering from a rare disease. And most experts will agree that this number is actually an underestimate because many of the rare diseases do not even get diagnosed or detected. But even at 70 million patients in a country is already more than the entire population of the state that I am currently sitting and giving this presentation from, which is Karnataka. Now, the real challenge here is not just the numbers, it is actually the journey these patients have to go through. So, on an average, someone with a rare or undiagnosed condition has at least 8 physician visits. They receive at least 3 misdiagnoses and spend over 7 years before finally being given the correct diagnosis. So, this is 7 years of uncertainty, repeat testing, and treatments that may not even be relevant or appropriate to their condition. And these are just estimates. There might be some patients for whom the diagnosis may not even come at all. So, once we recognize how long and painful the diagnostic odyssey actually can be, can the natural question be shifted from what is it to can we shorten this particular path that these people take? And this is where a genome first approach has shown remarkable results across multiple independent cohorts. So, in a large heterogeneous cohort from Pittsburgh in USA, it was shown that whole genome sequencing achieved a higher overall diagnostic yield when used as a first tier test. It picked up diagnoses that even whole exome sequencing missed initially, and it clarified partially diagnosed cases using whole genome sequencing. So, thus making WGS the clear first choice when the presentation is very complex. The same pattern was seen for another cohort in the USA funded by the NHGRI. So here, whole genome sequencing delivered a higher diagnostic yield across both big research settings and smaller real-world clinics. And very importantly, it uncovered pathogenic variations that exome sequencing missed and also other methods did not detect. So this reinforces that WGS isn't just an alternative, it adds real value on top of existing tests because it can be the one single stop that patients can go to now to get their answers. And finally, we have this evidence also coming from NHS cohort in England, and the message here is also very consistent that WGS is a powerful first line test because it captures things that other methods generally miss or take a longer time to detect, especially structural variations and non-coding variants, which often hold very important key in rare disease cases that were either missed in diagnosis or were never diagnosed. So, across countries, across healthcare systems, and across patient types, we have seen that the evidence points in the same direction that a genome first approach truly reduces the diagnostic odyssey for these patients. The next group where WGS becomes really very, very important is in children with developmental delays or congenital issues. And the numbers alone tell us how significant this population is. So, according to the Global Burden of Disease report by WHO, about 14% of kids that are aged between 15 to 19 years and 7.5% of children in the world under 5 years are affected by global developmental delay. And when we look at the underlying causes, copy number variants actually play a huge role in this. So, studies have shown that around 25% of individuals with developmental delay or intellectual disability have a causative CNV. Other cohorts have reported this number to be even as high as 30%. And these are exactly the kind of variations that whole genome sequencing is designed to detect with much higher accuracy, and tests like whole exome sequencing will fail to catch all these variations. And this is why very major bodies like the American Academy of Pediatrics now include whole genome sequencing as a tier 1 test option for evaluating children with global developmental delay or intellectual disability. So for this group, WGS is something that isn't really optional. It is rapidly becoming the standard first step to understand what is driving their condition and to guide early intervention in these cases. The next group where WGS becomes absolutely essential is families with histories that unmistakably scream genetic. And unfortunately, we see these stories more often than we should be seeing them. One striking example is this family from Agra, a father who actually wrote to the President of India asking permission to end the suffering of six of his eight children, all of whom were affected by a devastating neurological disorder. So all his children, the six of them, they were completely normal until the age of 3, and they gradually developed things such as seizures, motor impairment, and macrocephaly. For years, no one knew what was happening. There were multiple clinical evaluations without any answers. And it was only when researchers stepped in with genomic investigations that they identified a homozygous frameshift variation or deletion in the MLC1 gene, which is now known as the Nunbund mutation, according to the community in which this variation was found. So this mutation causes a disease called as megalencephalic leukoencephalopathy with subcortical cysts. And families like this actually don't need a long diagnostic odyssey anymore. Their history itself tells us that the cause is likely genetic. Whole genome sequencing as a single stop test can give answers and the ability to confirm it very quickly, accurately, and compassionately, reducing the diagnostic odyssey for all of these patients and their families. And one of the biggest advantages of WGS is that it collapses what used to be an entire series of separate tests into one single test. So, traditionally, if we suspect a genetic condition, we would often go step by step, starting with karyotyping or FISH for chromosomal abnormalities, then an array CGH or MLPA for structural changes, then specialized assays like repeat expansion testing, finally, panels or exome sequencing for detecting small variations. Now, each of these tests have their own turnaround time, often 2 to 4 weeks or more, and they are rarely done in parallel. So, the patient ends up moving through them sequentially, which stretches their diagnostic journey even further. Now, whole genomes can change that. They can detect all of these variant types at once, including chromosomal abnormalities, structural variations, repeat expansions, and small variations, all in a single assay with a single sample. So this one test approach doesn't simply just reduce the workflow or simplify it. It can dramatically reduce the time it takes for these families to finally get answers. And now the next group where whole genome sequencing becomes incredibly valuable is patients with complex disorders, especially those that don't really follow a straightforward clinical pattern. So one example of this is that fits this very perfectly is mitochondrial disease, often thought of as the great mimicker. So, why is mitochondrial disease a great mimicker? It is because these patients show extreme clinical heterogeneity. One child might present with vision defects or seizures, another may suffer from myopathy or autism spectrum features, all caused by the same variation. The age of onset is also highly variable. A 3-year-old and a 10-year-old can have the same underlying disorder but can look completely different from each other clinically. And to make things even more complicated, the symptoms for these disorders overlap with very common conditions, which is why 54% of the patients that actually suffer from mitochondrial disorders are misdiagnosed on their way to a mitochondrial diagnosis. And more than 72% of these patients are initially labeled with something else entirely. Often things like psychiatric disorders, fibromyalgia, chronic fatigue, or even multiple sclerosis. Now, 54% and 72% is a very large number of patients that eventually get misdiagnosed when they enter a clinic to get a diagnosis or answers for the disorders that they are having. And when the presentation is this broad and this misleading, a targeted test is often the wrong tool. Whole genome sequencing is uniquely positioned now here to cut through the noise because it doesn't depend on guessing the right gene. It captures everything all at once. So, for complex disorders that have a multisystemic involvement, a genome first approach can be the only way to reach a right diagnosis at the first step of their diagnostic journey. Now, when we talk about mitochondrial disorders, one of the biggest reasons that they are very complex is that the mitochondria actually comes with two different genetic blueprints, and we can think of them as two manuals for the same working machine. On one side, we have the master manual, which is the nuclear DNA, which controls the building and maintenance of mitochondria. So, this is our normal DNA. It includes more than 1,000 nuclear genes that contribute to mitochondrial function, and they follow the classic Mendelian inheritance that we see for other genes. And because so many different genes are involved, the symptoms can vary very widely depending on which exact gene is affected from the nuclear DNA. On the other side, we also have the mini manual for mitochondrial function, which is the mitochondrial DNA. And this is a small circular genome of approximately 16,000 base pairs only, which are present in hundreds or thousands of copies in each cell. It contains 37 genes in total. All of them are dedicated to the inner workings of the powerhouse of the cell. And now, unlike nuclear DNA, mitochondrial DNA is actually maternally inherited, and its impact or the impact of a variation in the mitochondrial DNA depends on the heteroplasmy level, which is the proportion of mutated copies that are present in a cell. So this is why severity can vary so very much even within the same family, all depending on the heteroplasmy level of a variation. And because mitochondria drive energy production, mitochondrial DNA disorders often hit very high energy tissues first. So, with two separate manuals controlling one system, it's not surprising that mitochondrial diseases show such wide range of presentations, and why now WGS approaches become very important for the diagnosis of these disorders. So, for mitochondrial disorders, it is not just which gene is affected, and for the mitochondrial DNA part, it is also very important to understand the two very critical H's in this spectrum of disorders, which is heteroplasmy and homoplasmy. So, these two concepts explain why mitochondrial disease can look very different from patient to patient, even within the same family. So, because mitochondria replicate very independently, each of the cells of our body end up with a different mix of normal versus mutated mitochondria, which is exactly what heteroplasmy is. And with every round of cell division, this mix can shift through a process called as replicative segregation. So, one cell may end up with 10% mutated copies and another with 40% mutated copies, another with 60%, and so on. Symptoms will begin to appear in a patient only when a proportion of mitochondrial DNA crosses beyond the disease threshold, which is often at a number around 80%, depending on the gene and the tissue. Below that threshold, the cell may still function normally, but above it, phenotypes will start becoming clinically very, very apparent. And in rare cases where all copies or a majority of copies of the DNA are mutated, that is called as homoplasmy. And for these cases, the disease is typically very severe and the onset is very early in life. So now this is why mitochondrial conditions are very tricky to predict, because it is not just mutation, it is the proportion and distribution of these mutated copies and whether that threshold is crossed in the tissues that matter or not. So, when we look at how complex mitochondrial disease biology can be, it is no surprise at all that the diagnostic journey is equally layered. It usually begins with a clinical suspicion of patients having neurological symptoms, multisystemic involvement, myopathy, cardiac issues, eye issues, and so on. These signs can often suggest that something fundamental like energy metabolism isn't working as it should be working. So then we look for biochemical clues in these patients, and the classic markers include elevated lactate, especially when it is persistent or unexplained. Next, neuroimaging may show characteristic brain abnormalities that can push the suspicion further. On top of that, we can check for morphological findings, especially the typical ragged red fibers that can be seen on muscle biopsy, which add a strong evidence that a mitochondrial function is compromised. Now, all of these pieces are integrated using tools such as the Nyman mitochondria score, which helps clinicians decide how likely a mitochondrial disorder is in a patient and whether we should move on to a genetic confirmation for these patients. And ultimately, this layered approach is something that points us back to the value of whole genome sequencing, because after all these clues, we still need a test that can capture both nuclear and mitochondrial DNA variations all in one go. So, this actually brings us to a new paradigm in how we diagnose mitochondrial disease, which is shifting from phenotype driven genetics to evidence based genomics. Traditionally, we followed a very reactive model that starts with a phenotype, interpreting clinical pictures, looking for a variant that matches it, which involves going through all the steps that are mentioned in the previous slide. But this approach struggles when the phenotype is very broad or misleading, which is exactly what happens in mitochondrial disorders now. And also, it increases the diagnostic journey for these patients quite a lot. A more powerful approach is a genome first approach, wherein we start by identifying pathogenic variations in nuclear and in mitochondrial DNA, and then we interpret and correlate them clinically. So, this often shortens the path to diagnosis and reduces misdirection for these patients. And this shift matters a lot, especially in countries like India, because recent population data coming from the indigenous study shows that 1 in 250 individuals actually carry a pathogenic mitochondrial DNA variation. So, these group of disorders are thus common enough that genomics can no longer be the last step, it needs to be the early first step for these patients. So, what makes whole genome sequencing so powerful in mitochondrial disease? Firstly, it lets us analyze both the nuclear and the mitochondrial genomes together, which is essential because the disease can come from either of these two. Secondly, it gives full comprehensive coverage of mitochondrial DNA, something that many targeted tests actually miss. And lastly, it allows us to measure heteroplasmy very accurately, which is absolutely critical for interpretation and predicting disease severity. And the impact of this is clear coming from real world data. In an Australian cohort of patients who met the criteria for mitochondrial disease, whole genome sequencing was found to deliver an overall diagnostic rate of over 50%. And in a UK study, whole genome sequencing provided a definite or probable diagnosis in another 31% of cases that previously had no answers for the condition. So, when it comes to mitochondrial disorders, whole genome sequencing isn't just helpful, it is very transformative as a first line testing approach. And to make this clearer with a very tricky clinical case that we saw. So one of the biggest strengths of whole genome sequencing is the ability to handle these tricky presentations in patients, and basically the cases where symptoms don't immediately might point to a mitochondrial disorder. So, for example, take the 3-year-old boy on the left. His presentations included global developmental delay, autism spectrum disorder, ADHD, and developmental encephalopathy. All common non specific features that could easily lead clinicians down multiple different pathways suspecting a neurological disorder. Or you take an example of this 36-year-old man on the right whose symptoms looked perfectly and completely different from what is seen in the patient on the left. So, this patient had early onset Parkinson's, cervical dystonia, dyskinesia, bradykinesia, and unexplained weight loss. So, nothing here in these two cases screams that these actually have the same disease. But whole genome sequencing revealed that both of these cases shared the same pathogenic mitochondrial DNA variation in the genes MTND1 and MTRNA1. So these two genes are associated with conditions such as MELAS, mitochondrial A syndrome, and LON. The sequencing depth and heteroplasmy levels were high enough to give absolute confidence in the result, although the heteroplasmy levels vary very in a very less significant manner between these two patients. So, this brings us to the conclusion that coverage heteroplasmy level in mitochondrial DNA is something that can affect the diagnosis and the clinical presentations very minutely also. So, here we have two patients with two very different phenotypes, one both having an underlying mitochondrial cause. And this is exactly where whole genome sequencing shines, because when the presentation is very misleading, the genome actually clarifies these cases. Coming to the next group where whole genome sequencing is very, very important, and this group is very straightforward. These are patients who have already been through gene panels or even whole exome sequencing but still don't have an answer. And the truth is that these older technologies miss a lot of different things that whole genome sequencing covers if used as a first line treatment or diagnostic option. Panels are restricted by design. If it's not the right gene on the list, then you will actually not find anything in it. Whole exome sequencing improves coverage across these genes, but it still struggles with structural variations, copy number changes, repeat expansions, mitochondrial genomes, and variations that are not resolved quite easily on a whole exome sequencing test. So, whole genome sequencing overall covers all of these limitations, and this is why we see a massive jump in diagnostic yields compared to whole exome sequencing or other types of tests. So, 73%, for example, in congenital heart disease, 57% in inherited retinal disorders, and very significant gains in unexplained epilepsy and kidney diseases. So, these are cases where panels and whole exome sequencing has already failed. So, when the earlier tests come back negative or unclear, it's not that the patient is undiagnosable, it is simply that the technology we used to diagnose them was very, very insufficient. We used a far less superior technology to actually diagnose these patients. So, whole genome sequencing, in summary, is simply the more complete or the better technology and the far more superior technology to diagnose these patients, simply because of the reason that the diagnostic yield is much higher compared to other tests. So, for example, this is one of our own cases that we saw here, and it really shows what's at stake when the right test isn't used early enough. So, this is a 5-year-old boy who had already spent years in the healthcare system with more than 20 symptoms cropping up, multiple evaluations, and a working diagnosis of global developmental delay, dysmorphism, failure to thrive, and muscular neuropathy. In other words, a 5-year-old diagnostic odyssey with no clear unifying explanation. So, for this patient, whole genome sequencing test was eventually done, and it changed everything. It identified a single actionable cause, which is a likely pathogenic variation in the CACN1AC gene, which immediately shifted the diagnosis to a CAPNA1C related disorder, which carries a hidden but life threatening risk of cardiac channelopathy, like long QT syndrome and Brugada syndrome, for example. And the kind of symptoms that are correlated with this disorder matched exactly what the patient was experiencing. And because of this one WGS test result, his care moved from uncertainty, thinking that he has a neurological condition, to preventive and treatable care. He was started on life saving beta blocker therapy also to reduce the risk of sudden cardiac death. And this is now the power of WGS. It's not just finding answers, it is finding ones that change the outcomes very significantly and very early for particular patients. And now the next group where WGS and genetics become very extremely important are patients whose treatment choices may depend on their DNA. And this is becoming much more common than we think about it. So, for example, in chronic kidney disease, about 20% of patients have genetic findings that are actually changing their diagnosis. And in one third of them, the treatment itself is modified based on the result. In immune thrombocytopenic purpura, 11% of the patients we have been reported to have genetic findings that directly shape treatment decisions and outcomes. And outside rare diseases, we are now seeing genetics enter mainstream care. So, for example, the NCCN guidelines already recommend preemptive DPYD germline pharmacogenomic testing for patients receiving fluoropyrimidines for solid tumors. And just because a single variant can determine whether this drug is safe or life threatening for that patient. So these are no longer academic findings. These are real world examples of how DNA and genomes guide therapy and why genomic testing is increasingly becoming a part of routine evidence based care for patients. And the next group, which is where genomic testing is absolutely critical, which is the neonatal ICUs and pediatric ICU patients, cases where time truly matters. So, for years, we have assumed mostly that prematurity related complications were due to external factors like immaturity, injury, or interventions. But we now know that that's only a part of the story, because even newborns with the same clinical condition and the same treatment can have very different outcomes. The new insight here is that a baby's genetic makeup plays a very major role in how they respond to illness, exposures, and even the treatments that we give. And the numbers are very sobering. 14% of NICU babies have an underlying genetic cause or a congenital disorder. But the most heartbreaking statistic of all of this is 33% of critically ill infants in the neonatal ICU with a suspected genetic disease will actually die before they ever receive a diagnosis. And now, this is why rapid genome sequencing in intensive care settings isn't a luxury. It is a lifeline for these patients, and it is often the only way to give these babies a fighting chance. So, why whole genome sequencing for newborns? Because early life is when time matters the most. And in a recent study, it has been shown that genome sequencing identified 120 babies, which is approximately 3% of their cohort, with a serious but treatable health condition. And the striking part of this is only 10 of these 120 were picked up by standard newborn screening, which means that 110 babies out of their complete cohort would have been completely missed of having a congenital disorder. One example was a newborn with severe combined immunodeficiency, which is a life threatening condition that standard screening could not detect. Whole genome sequencing found the variant early enough to allow a curative bone marrow transplant in that baby, literally saving life and time for that patient now. And rapid genome sequencing pushes this even much more further. It cuts the average time of diagnosis from 289 days to just 13 days in a pediatric setting. So, this is data coming in from the real world that for pediatric and neonatal disorders, whole genome sequencing is something that can cut down the time to diagnosis and treatment much lower than previously. So, for newborns, WGS isn't about more information, it is about intervening before the window of development for these newborns closes. And this is a powerful real world example of how rapid whole genome sequencing can completely change the course of care for a newborn. So, at the Kokila Ben Hospital in Navi Mumbai, which is a very popular hospital, a 1 day old baby in the NICU presented with severe jaundice, high retic counts, and falling hemoglobin. And none of the standard treatments were working. The doctors were perplexed about what to do. So they immediately moved on to rapid whole genome sequencing looking for answers. And because of the nature of rapid sequencing, the report was given to them in just 3 days. So from sample collection to the report, it took just 3 days. And the genome of the baby revealed a heterozygous missense variation in a gene called as SLC4A1, which confirmed that the child suffers from autosomal dominant spherocytosis with associated renal and hematological features. So, this single test result that was given very quickly to the patient allowed the clinical team to change treatment right away, starting oral alkali and potassium chloride replacement therapy to correct the chronic metabolic acidosis that the patient was having. So, in other words, a diagnosis that would have normally taken weeks of or even months of trial and error was delivered absolutely in days. And the baby received the right therapy when it mattered the most. Now, coming to the next thing and to the last category of people who can benefit from whole genome sequencing, these are healthy individuals who want to just stay healthy. So, genomics isn't just for solving medical mysteries or managing complex disorders, it is also a very powerful tool for prevention. And we have heard it from our childhoods that prevention is always better than cure. So, for example, you don't need to be unwell to benefit from whole genome sequencing. You can be basically anyone if you are curious about your health. So, take for example this 50-year-old gentleman who was completely asymptomatic, wanted to up his health game by becoming more fit and active in life, but wanted to get his whole genome sequenced first to know his health insights better. His whole genome sequencing revealed a pathogenic variation in a gene called as MYH7, which puts him at a higher risk for developing hypertrophic cardiomyopathy and even sudden cardiac death events. So, because this was detected early, he can now follow a proactive plan, which includes cardiac checkups done regularly, early medications if needed, and lifestyle changes that significantly reduce his risks for developing a severe cardiac event. And all of this he did before starting his physical health journey, so there was nothing unexpected that can now happen in his life. So the final message here is very simple: you don't need to be unwell to benefit from whole genome sequencing. Sometimes it's actually something that keeps you well. And this becomes much more important if you realize the fact that medically actionable genetic findings aren't rare at all. In fact, they are present in 1 in 20 of us. So, which means that if we have 100 people listening to this webinar right now, 5 are carrying something in their DNA that can change how we monitor, prevent, or treat a disease. So, for example, around 10% of all cancers are hereditary. Approximately 2% of the general population carries a genetic risk for hereditary cancer. Another 2% carries actionable risk for conditions such as cardiovascular disease, familial hypercholesteremia, cardiac channelopathies, cardiomyopathy, and certain treatable intellectual disabilities, even metabolic disorders like Wilson's disease. So, even in people who feel perfectly healthy, genomics can help uncover risks that are very preventable, treatable, and manageable long before symptoms start appearing. And the last piece of all of this is pharmacogenomics, because this truly affects every one of us. Medicines is something that we can't avoid even if we want to in life, and they don't really work the same way for everyone. And genetics is a major reason why. In fact, if we speak about India, on average, every Indian carries at least 8 clinically actionable gene variants that influence how they respond to very commonly used drugs. Whether a medicine works or not, whether it causes side effects, and whether it needs a different dose altogether is something that is determined by these pharmacogenomic findings. So, PGX isn't just a niche area, it's not rare, it is a part of daily healthcare, and it's one more reason why genomic testing has something meaningful to offer to every individual. So, when we step back and look at the complete spectrum of healthcare, it becomes clear that the applications of WGS are truly pervasive. Genomics is no longer limited to diagnosing rare diseases, it spans the whole timeline of clinical medicine. So, from identifying germline risk in completely healthy cells to screening before symptoms even appear, to making a precise diagnosis when disease actually begins, to guiding pharmacogenomics and treatment decisions, all the way to monitoring recurrence of a disease. WGS has a role at every single stage of this clinical process. So, in other words, genomics isn't something that we should turn to only when things get complicated. It is often now becoming a foundational tool that supports clinical care from preclinical health to active disease and beyond. So, in summary, after everything we've talked about today, the final question is very simple. Who needs a WGS? So, it's the person with unexplained symptoms. It is the one caught in a long diagnostic journey. It's the individual with a strong family history. It's someone who needs clearer answers for their disorders, but it is also much broader than that. So, it can be the person who takes medicines. It can be the person who wants to plan a family. It can be one who is a bit curious about their health, and it can be the one who's reading this slide right now. Because, in one way or the other, genomics has something meaningful to offer to each one of us. So, the real conclusion here is WGS isn't for a few people, it is actually for everyone. So, support the hashtag WGS for all. Thank you. We'll be taking questions now, so feel free to post them in the chat box again.
Wow, that's a wonderful session, Dr. Bani. So, uh, this is really great. Like the kind of idea and the kind of insights that we are getting from the sessions is really amazing. And I can see a lot of questions here in the chat box. So, one of the questions is that the first reason is cost. Second reason is that we are trying to identify if WGS can also replace tests like FISH and MLPA.
Right, the question of cost will be irrelevant very soon, because if we think about it, the cost of doing a whole genome sequencing today is actually lower than what it took to do a whole exome sequencing a few years ago. So cost is something that is driven by application demand, changing technologies, and it will all come down very, very soon. So it's not the cost that is now the limiting step for a particular test anymore. It is how well and how ready are we to adopt it into our regular clinical practice. And you all have taken the first step for it by understanding how to interpret all of these tests by attending this webinar.
Awesome.
So the second question was about if it can replace fish MLPA and karyotyping basically. Yes, absolutely, because whole genome sequencing does detect structural variations, deletions, and at a resolution that is something that is not picked up by these standard tests. So smaller deletions, smaller exonic variations, and things such as small exon deletions and duplications can actually be picked up better on a whole genome sequencing compared to these other methods, because those other methods are very limited in terms of how well somebody is handling the assay, what are the different probes that are being used to put up that assay, and so on. So yes, WGS workflow in terms of the laboratory workflow is very unbiased. It is very easy compared to these other methods, and which is what makes detection of these changes that are detectable on fish and MLPA much easier, faster, better, and high resolution and high quality sometimes.
Awesome, awesome. That Thanks a lot for that response, Dr. Bani. There is actually another question about what about in India? Do we use WGS as a mainstream diagnostic test? And a user has actually responded back. Accidentally, the user might not be aware. The user has responded that no, not yet. We are not using WGS. But to answer that, in reality, we are using WGS extensively in India. A lot of the major practitioners who are actually the thought leaders on the field and has have started using it in various fields. I would love Dr. Bani to explain further on this.
Right, so absolutely. A lot of clinicians in India have started realizing the diagnostic power of WGS, and now that cost is something that is not really a factor, because if you factor in the wide array of tests that a patient has to go through to get a negative answer and then to finally move on to WGS for a final last ditch effort, the stepwise cost is actually much more for a patient compared to this one single test that they can do at the first step itself. And thankfully, a lot of clinicians have started realizing this, especially in the domains of neuro. So, yes, WGS is being practiced in India, especially when the cases that you see are complex enough to run to genomics for answers. And the diagnostic positivity is something that is unmatched by panels and whole exome sequencing, simply because if CNVs are a cause of a disorder, then these standard tests will not give you an answer. And we've seen it coming from real world data that 25% of the cases actually have a CNV. So these are 25% of cases that you will miss if you go in for a whole exome sequencing, which will not give you CNVs. So yes, the shift is happening, and glad to see these participants today trying to be a part of that shift. And that so whole genome sequencing is not really the future. It is something that is happening right now in India, and not just standard whole genome sequencing, also rapid whole genome sequencing. As you saw in my slides, we were able to give back a report in mostly 3 to 5 days at maximum for very critically ill newborns. So it is happening. So
Yes.
better
And
to
so,
be on board that train.
yes, it is happening. And so, what I'm feeling right now is that whole genome sequencing is becoming the this generation's biochemistry. How biochemistry impacted the previous generation. Anyone in this generation is getting impacted by whole genome sequencing in the similar way. And on continuation to it, there's a question by Charvi R. Again, maybe a loss of construct due to which the person might be posting the question here. Is that whole genome sequencing data from Illumina, NovaSeq, does not give 30x coverage for all regions. Some 20 reads, of which 6 are of variant, are seen well in center in BAM reads. This is more of a technical pipeline workflow question that the person might be having. Would you like to answer that, Dr. Bani?
So, if you follow the laboratory workflow as prescribed by Illumina well, then the uniform coverage that you will get across the genome will actually be at least 30x if you target it. And the clinical samples that we have seen usually do follow this. So the average coverage that we see across the genome will be 30x. There are certain complex regions in the genome, such as repeat regions, that are very, very rich in these repeat sequences, where you might find that the coverage is a little aberrant. But these are not some regions that are these are not problems that are not unsolved. So the Illumina analysis pipelines actually considers these regions as special regions while considering their analysis and developing their analysis softwares. So the repeat regions have a different workflow to work through these variations, and even for example, genes that have a pseudo gene available, these are problems that uh, analysis groups are now solving. So a lot of these genes have been solved by Illumina itself. So for example, the HBA gene, which is known to have a pseudo gene, is something that Illumina offers a specialized caller for. So it's not that the Illumina data is giving you an aberrant or a non-uniform coverage. If you follow the set guidelines for sequencing, library preparation, analysis, and reporting, the data is actually very, very high quality.
Awesome, awesome. Thanks a lot, Dr. Bani, for that response. I'm just glad that we are not teaching people WGS about whole genome sequencing here. We are not advising the next generation on what is happening, but we are also pushing boundaries for the older generation, teaching them that might be old and outdated, converting them to the latest knowledge through the session today. Further adding on to other questions. From the same user, there's another question asking for free platforms, if anything, are there to reanalyze WGS data for a clinician.
By free platforms, if they mean something that is open source, yes, some certain companies have developed softwares that are accessible through a web browser wherein you can upload your genomic data and basically assist yourself in your reporting process. So, for example, tools such as Variant Effect Predictor exist if you want to do the ACMG annotation by yourself. There are tools such as Franklin that gives you the very tentative ACMG AMP guideline classification for variants also. So as and when the applications of genomics is increasing, the number of tools that are cropping up to aid analysis, interpretation, and reporting are also increasing. So yes, these tools are available and you can give them a try.
Awesome, awesome. Thanks, Dr. Bani, for
So I would
answering.
like to take up this question that somebody has asked in the comment box, which is related to if uh, detecting an incidental finding that will cause a disease later on, cause anxiety and trauma for a healthy person in which they have detected it in. So this is a perception that we all hold, and very honestly speaking, I too felt that if I discover something that will happen later on in life and is uncovered through whole genome sequencing, it can actually lead to a lot of anxiety and psychiatric issues coming up in my mind because of the entire uncertainty of it. But it's a misconception because all the healthy people that we have sequenced actually had a very, very solid healthcare plan laid out in front of them once they detected these findings in their genome. It did not cause them anxiety, which was the preconception that we had. It did not cause them trauma. And even though, as a part of the counseling process, we mandatorily asked if they wanted to know these findings or not, and all of them said yes. If we are paying for a test that is future proof, we don't want to know everything that can happen to us now and in the future. So if you ask your patients, if you ask the people around you who are willing to get a test done, they will actually opt in for it in the majority of cases. And if they have a plan set in that can guide them through all of this, then the anxiety and the uncertainty of all of it actually reduces compared to what we think might happen. So all of these are actually anecdotal evidences that we think that knowing something that can cause something in the future might cause anxiety and trauma. It is not something that is backed with actual data. So these might be one of cases that we think considering ourselves in that position, but for most of the people, they want to know everything they can about their health if possible.
Absolutely, absolutely. That's the assumption versus the presumption. What is going on here? I observed while in most cases where the patient is critically ill. This is again more of an observation from what I've seen being on the field, interacting with patients, physicians, and general population, what I've observed is that there might be a little bit of skepticism for maybe 1 to 2% of the patients to know that what are the other factors, disease factors that they might be having that can be analyzed through whole genome sequencing. But most of them are willing and more interested to know, at most cases more than the physician, interested to know what is going on with their body so that they can better plan for themselves. In the end of the day, one of the two aspects that drive them to take all insights from a WGS report is, one is that they feel that they should know much better about themselves than anyone else, so they can take a very good precautionary measures. The other key aspect is that, okay, now I'm having this disease. If I'm taking care of this disease, and if I also know about other disease factors that I might be having or that I may be having in the future, I can preemptively start thinking and planning in that angle. So that is something that is extremely beneficial, and the thought process of the patients nowadays in active clinical practice that we are seeing on the field. So great questions. Um, in the spirit of a small break, I'd like to request if Dr. Bani, we can take a short break and maybe come back to more interesting discussions and maybe an activity involving all the listeners and all the people who have tuned in to the session. Is that the next thing to do, Dr. Bani?
Right, absolutely. So let's maybe take a small 5 minute break and join back at around 11 a.m. IST to move on to the next session, which is a demo and a hands on how you can look at WGS data and interpret it. So, looking forward to continuing this discussion even further. Let's meet after 5 minutes, probably.
Awesome. Let's break for 5 minutes. This is to catch your water bottles. Come back. We are having a hands-on demo. This is the first time we are having a hands-on demo on a Knowmics course. Would love to have you all back and learn this. There is also a special gift awaiting for the stakeholders who are taking the course. Looking forward to supporting you. Let's break for 5.
Welcome to Karkinos Healthcare's network of Advanced Center for Cancer Diagnostics and Research Labs. As a technology-led, purpose-driven oncology platform, we operate 6 state-of-the-art labs across more than 120,000 square feet. Our histopathology division offers a complete range of services. From routine tissue analysis to advanced immunohistochemistry for biomarker detection, fluorescence in situ hybridization for genetic abnormalities, and special stains for enhanced tissue insights. Every sample receives the most detailed and clinically relevant evaluation. Efficiency is at the core of our operations. Through advanced automation and technology, we ensure industry-best turnaround times, cost efficiency, and seamless logistics, delivering temperature-controlled sample collection and rapid reporting right to your doorstep. As part of our molecular diagnostics, we offer over 70 unique molecular tests, which are tailor-made to provide clinicians with critical therapeutic, prognostic, diagnostic, and actionable insights. Our test menu is continually evolving to reflect the latest research and clinical guidelines, ensuring access to state-of-the-art diagnostics. We employ cutting-edge technologies, including the thermo sequencing platform, featuring the Ion Chef for automated sample prep and the Ion Gene Studio S5 sequencer for diverse oncodiagnostic applications. The Genexus system offers a fully automated NGS workflow, from sample to report. At the heart of our innovation is sequencing at scale. 2 NovaSeq 6000 systems with 3 Illumina NovaSeq X Plus. We also house India's first PacBio Revio ultra-long read NGS sequencing platform. With India's largest private sequencing capacity, we offer rapid, targeted, custom, and comprehensive genomic sequencing for clinical and research needs at affordable costs, while also delivering results twice as fast as the industry standard. Our team of leading Indian scientists, clinicians, and technologists, combined with our commitment to scientific rigor, truly distinguishes Karkinos. Join us in making personalized medicine a reality for every Indian. At Karkinos, we believe every life deserves the best chance. And we are here to make that vision a reality for all, today and for generations to come.
So, hello and welcome back, everyone. And before we begin the demo and hands-on session, I would like to take this slight buffer time to now introduce two very important people who have been very pertinent to this course and its organization. So first of all, Mr. Harish Ramanathan, who is also our host today. So Harish is the manager of technology at Karkinos Healthcare and he works out of the Navi Mumbai lab, where he bridges healthcare and technology to support innovative cancer care solutions. Harish has a very strong foundation in biomedical engineering from Anna University and an MBA in health IT management from IIHMR University. He brings a very unique blend of technical and strategic expertise, and his diverse professional journey includes leadership roles in the US healthcare market research, and a lot of digital health initiatives, including stints at the Spry Movement app, Truly Human Consulting, and the Data Congress, where he served as a managing director also. He has also gained experience in operations and research at Narayana Health, further grounding his understanding of the Indian healthcare system. He is known for his entrepreneurial spirit and systems thinking, and Harish is very passionate about leveraging health informatics and digital tools to drive impact on patient centric care. And thank you, Harish, for organizing this, for holding up as a host in all of our sessions. Truly appreciate it. And the next person we have here today is somebody who rarely shows his face to anybody in the world. And this is Mr. Rajdeep Raha. So, Rajdeep Raha is a senior bioinformatician at Karkinos who turns raw genomic data into real clinical impact. He builds end to end genome sequencing pipelines, automates high throughput workflows, and manages the high performance computing and large scale storage systems that keep modern genomics running smoothly and very nicely in our company. So, in short, when the system misbehaves, he is the person that the system is actually scared of. His expertise sits at the intersection of genomics, bioinformatics, infrastructure, and research, developing in house ACMG variant classifiers, contributing to clinical studies, creating automation that scales seamlessly from lab to clinic. And of course, he is known across teams for two things. One is his brutal honesty and the legendary power of I got it. So when he says it, you know the problem is already halfway solved. He has spent nearly 3 years now here at Karkinos Healthcare working across cancer genomics, workflow engineering, large-scale data management systems. And before that, he has dabbled in machine learning, MERN development, data science. He holds an MSc in bioinformatics and computational biology and is actually a bachelor's in chemistry. So most of the tools that you will see us using here today are something that have been developed by Rajdeep here. So thank you again, Rajdeep, for organizing this and for developing everything that we needed to work this course out today. So moving on to the demo session now.
Thank you,
And
everyone, for the overwhelming introduction.
thank you, Rajdeep, for speaking up, which is something very rare if you don't know him. Right. So, which brings us to the hands-on and the demo session for today. Right. So now it's your turn to actually look at the data and see how to interpret it and convert it into something of a lot of clinical meaning to it. So, before we move on to how we interpret variations that may be detected in a whole genome sequencing report, how these variants are reported are something that follows a particular set of guidelines that have been put together by the ACMG and the AMP consortium, which is basically the joint guidelines for interpretation of pathogenicity of germline variations. Now, you may have heard about these guidelines. They are basically a set of 28 different standard attributes that we can apply to a variation to classify them as either pathogenic, likely benign, or a variant of uncertain significance. So these are a set of 28 standard guidelines distributed over 28 ACMG parameters that can help us understand whether the variant is more inclined towards being a pathogenic variation or a benign variation. I will not go through these very complicated guidelines in this session. All you need to understand is that these guidelines and these attributes that are there, they all come from some data that can be used from a different set of resources. Now, this may be computational data, population data, data related to the type of the variation, a lot of databases that curate information that is important for a variant's classification, functional data coming in from labs in across different publications, segregation data for a particular patient family, case versus control data, and the allelic information for this variation. So this is where the evidence of these attributes comes from for classifying a variant as either pathogenic, likely pathogenic, benign, likely benign, or if nothing is attributable to a particular variation, it then becomes a variant of uncertain significance. So all you need to know now for this course is that the clinical classification of variations follows this process, or this scale rather, which is ranging from pathogenic, which are harmful variants known to affect the function of the gene as given by the different evidences that can be applied for it, all the way to benign, which are variants that have an evidence that tells that this variant may be harmless or a normal variation. So the output of a whole genome sequencing test that will be given by any lab or any machine running anywhere is actually a file called as the variant call format file, or a VCF file. And it looks something like this. Now, what you need to know now here is that the VCF file will be something that contains all the variants that have been detected by a particular test. So now you can imagine a whole genome sequencing VCF file will be a very, 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 very large text file that you don't really need to read through, because there are tools that can now sift through those variations in a VCF file and give you information that is clinically interpretable. So the task of now classifying these variations in this VCF file as pathogenic or likely pathogenic or benign and likely benign, and filtering them out when looking at a clinical scenario, becomes much easier thanks to these tools. And one of these tools that we'll be using for the learning and teaching process just for this course is something that has been developed by Rajdeep specifically for you to use and understand for this particular course, which is known as the Seek-L tool. And L here stands for 11 from Stranger Things, who has these superpowers into understanding people, understanding the things that are happening in the world, and using them to benefit the world. So, as powerful as L is, we are now trying to develop this AI guided powered analysis for teaching purposes. And you can access this link here, that access this tool at the link given here. So this automated ACMG variant classifier is something that we will be looking at today. And before we begin the demo session, I would like to point you to some key resources that are present in the document that was shared with you previously. And you can access all those links in that particular document now. So for example, if you want to access the clinical classification tool, the link is present in this live link document. You can access it here. We will be using VEP, or variant effect predictor, a bit in this demo session. So you can use any of the links that are opening correctly for you. The VCF files that we will be using for the demo and the hands-on are something that are available in this folder. And for the submission of the classwork that we will do after the demo, is the link this is the link that you can use to do that classwork submission. So now, for example, let's look at a clinical case. Right. So, for example, we have a 42-year-old man who was diagnosed with colon cancer after presenting with mild and persistent abdominal discomfort. So, and the tumor appeared very unusually early for his age. He mentioned that two of his relatives had also developed colorectal or endometrial cancers before the age of 50. And because of this pattern, his healthcare team suspected an inherited cancer syndrome. So now they plan to start chemotherapy using this drug called as Adrucil. So this is the first case that we are looking at for just a demo, and let's see how to go about it. Now I have a file, a VCF file that was given to me by the sequencing machine, and I will use it to analyze what are the different variations present in this patient that can be of importance to his current healthcare condition. So the first thing that I need to do is I need to go to variant effect predictor. That is a tool that can help us process our VCF file and attach much more meaningful information to that file, which is a step called as annotating the VCF file. So for annotating, I will go to my files and I will upload the VCF file that was there for this patient. And now, since I want every information that might be important to understand what each variant means, I will go ahead and select all different options that can help me annotate this file against different databases using VEP. So for example, I want both Ensemble and GenCode RefSeq transcripts. So I will select this option here after uploading my file using this button. And very important to note while using VEP is that the reference genome mentioned here should match the reference genome assembly that is there for your file also. So for me, it is GRCH38, so everything is in order. So now I'll go ahead and select ensemble GenCode and RefSeq transcripts. And now it is very important to note that what is the order of the selections that I'm making, because the classification tool will actually depend on the input that you're giving it. I'll then go and expand identifiers and select everything that is available, because I want to attach all the possible information to my variants now. So I have selected everything. Then we go to variants and frequency data and we select everything yet again. So 1000 genomes, Nomad, all of us. Since we are not using an SV file, we can skip this option and let it be disabled. We can include flagged variants, we can include open target genetics. Then moving on to additional annotations, we need to select again all of it that pertains to small variants and not structural variants. So canonical transcripts, miRNA structure, NMD, UTR annotation, let's just go ahead and select all of it. I'll enable this. I'll click on all of these. Functional effect, I'll enable all of these again. I'm basically saying, yes, please annotate these pieces of information against my variants for everything that is possible apart from structural variants. So this I can keep as disabled. Now we go to predictions and we select SIFT, polyphen. We can leave this as disabled. So DBNSFP is something that I have kept as disabled, but I will also go ahead and enable alpha missense and CAD and let the default option come in. Then Reveal, ClinPred, Eve, and I will go ahead and enable Splice AI. Now Splice AI is something important to enable because it gives us the splicing score for non-coding variations. Then Blossom 62 and Ancestral Allele. So basically I have marked everything as to be included except when things required structural variant information. Now for this option, I don't need a filtering option and I don't need to apply advanced options. So I will go ahead and click on Run. So this will submit the job to VEP and you can see that it is currently running. You can see the status of your job here, and if you want to refresh and see if it has been processed or not, you can click on refresh to view the current status. Now for the interest of time, I have already done this previously and annotated these variants and have an output file for it. But usually it does not take a lot of time to run for very small files that we are using as a demo here. So the job should be completed pretty soon. So yes, now the status has been updated to running, which means that my variant annotation job is currently being processed by VEP. Okay, let's wait for a few more seconds. And yes, we see that the job has been done. Now we click on view results here to go to the annotations page. And this is basically how VEP will give you the results for all of this. But we don't need to really look at all of this information here. We just want to go to this button and download the VCF file for these annotated variants that we have. So a very important step here is that while downloading, you need to name your file a bit appropriately by giving it the extension .vcf and saving it as all files so that it gets saved as a text file in your system. So I will go ahead and give it the extension .vcf, click on all files and then click on save. And now the annotated file has been downloaded to my system. Now I go to the very important tool that has been developed by us for this teaching and learning purpose, and I will go ahead and upload my BCF file here. So here you will probably have to change this to include all files, and then click on this file here, and then click on classify sample. And again, your job will be submitted and you can view the status of it here. I can see that this job is running. And if I want to again check the status in real time, I can click on refresh. And if I'm very impatient, I can keep clicking on refresh until it is done. So pretty fast, it is now completed and I can click on and view the results. Okay, so out of the very small variant file that I had for this patient and I had submitted on to VEP just for demo purposes, I now see that 1, 2, 3, and 4 variants have actually come out in this report. The first variant is a variant in chromosome 1, and I can actually click on it to expand it more. The variant is in chromosome 1, the change is from A to C, and the change is in a gene called as DPYD. The classification according to ACMG parameters that this tool automatically applies is of uncertain significance. And the inheritance is autosomal recessive. The phenotype is DPYD deficiency. Now, if I look at the second variant, which is a variant in the gene called CFTR, the classification is likely pathogenic. Interpretation is carrier because the patient is heterozygous and the inheritance pattern for this disorder is autosomal recessive. Then if I look at the third variant, it is a variant in a gene called as KCNQ1. The evidence is this. Interpretation is that the patient is affected because they are heterozygous, but the disorder is autosomal dominant. And it causes things such as short QT syndrome, atrial fibrillation, long QT syndrome 1, and so on. And then I have the last variant in a gene called as MSH6, classified as pathogenic, the evidence or the attributes being these. And the interpretation is affected because the inheritance pattern is autosomal dominant, and it is known to cause colorectal cancer, hereditary non-polyposis, and so on. So if I now go back to my clinical case using this information that I have, I see that the primary finding for this patient is the pathogenic gene variant found in the MSH6 gene linked to Lynch syndrome. So, and the incidental finding is the pathogenic variation we found in the KCNQ1 gene that is linked to certain cardiac channelopathies. And we found that there was a variant in the CFTR gene linked to cystic fibrosis. Now, all these findings have a very clear action plan that we can take for this patient. So, for example, finding an MSH6 gene variant linked to Lynch syndrome can help us provide genetic counseling. Consider family testing for this patient, given that this patient had very early onset colorectal cancer compared to the standard age of onset for these tumors. We can adjust surveillance now, knowing that there is a genetic component for his cancer development, and also note potential treatment impacts from all of this, because MMR deficient tumors, which are supported by the MSH6 genes, can possibly benefit from immunotherapy. The incidental finding that we got in the KCNQ1 gene linked to cardiac channelopathy can help us now start cardiology referral for this patient, in which they can review his ECG and echo at regular intervals, adjust medications, and avoid giving any drugs to this patient that prolong the QT of the heart. And then also can support family testing if in case other members of the family are also affected due to this mutation. And the carrier finding for cystic fibrosis can help family planning for other members of the family using the same genetic report. Now, a very important component of this tool is if you scroll up, you will also see a button that shows you view PGX. If I click here, I can view the pharmacogenomics report for this patient in the same tool using the same VCF. And checking this report, I can see that the initial 3 entries are something that are very important, because they tell me that there is a variant in the DPYD gene, which is this, which is associated with these 3 drugs called as the 5-fluorouracil drugs, capecitabine, fluorouracil, and tegafur, which puts the patient at an increased risk for developing an adverse drug reaction to this particular drug. So now I know that the clinicians for this particular patient had actually planned to start chemotherapy using adrucil, which is a 5-fluorouracil drug. And using this pharmacogenomics information, we know that a DPYD gene variant linked to increased risk of toxicity to 5-FU chemo drugs is present. So the clinical team can now decide to not treat with this adrucil drug because the patient is at a higher risk for developing toxicity. So they can look at alternative ways or alternative drugs that can be used in this patient. So this is the exact workflow that you all can also follow using the sample VCF that we have given in those resource links. So the process that you will need to follow is you can go to this link, click on it. You can download this VCF file, which is named as WGS course VCF2 classwork. You will first need to go to variant effect predictor and input everything as I had shown in my demo session. You will then need to, when the job is done running, you will need to click on download VCF option, save it as .vcf, save it as all files, and then click on save. And then you will need to go to the variant classifier tool and upload that downloaded file and click on classify sample. And then you can view your job submitted as a queue here, and you can view the status of your job in this right pane that is shown here. And if you don't want to do all of that hard work, we have already kept the annotated VCF file in this folder, so you can directly download this and process it using the ACMG classifier tool that is available at this link that is present in the same document. And now, to help your clinical interpretation for this particular VCF file, we have another hypothetical case that we will look at. So the VCF file that you will be downloading and analyzing is for example, a 28-year-old woman who came in for a routine checkup and was found to have extremely high LDL cholesterol of over 340 mg per dl. And despite being fit, active, and eating well, her cholesterol has been high persistently. She mentions that her father had a heart attack at the age of 42 and her grandmother had a cardiac event at the age of 50. Her physical exam also revealed something very, very significant that she had never really noticed before. Her doctor thus suspects a hereditary cholesterol disorder. So, this exercise is now for you. You can go ahead, download that VCF file, interpret it, and then fill in the Google form that is present at this link. So, in this form, you will have to fill in your name, your email address, and basically answer questions such as what is the primary finding that you have detected in the patient depending on the genome result interpretation? Is there any incidental finding? Are there any pharmacogenomics variants that may be related to the case that we are presenting here? And what is your final interpretation and understanding using the genomic and the phenotypic data for this particular patient? So you have approximately 15 minutes to go through this since it's a very easy case, and you can download the file and then you can try it out and we'll look at your submissions later on then. So please go ahead, feel free to use your tools and feel free to post any questions if you have in the chat box and we will take them up. So yes, use this time to now look at the case and try out a hands-on on the variant interpretation. So this is just a reminder to everyone who is trying out the hands-on exercise. For viewing the pharmacogenomic SNV information, you will have to click on the View PGX button that is given on the top of the report. So if you want to fill in the appropriate PGX result in the Google form, you will have to look at the report that is being rendered through that button. Okay, so we have actually received a lot of submissions for the assignment, and it makes us very happy that almost all of you have got the correct answer for this. So, those of you who are still trying it out, don't worry. We will also be giving this entire process to you as an assignment after the course, so you can play around with the tool, and we'll be keeping the tool live for a bit more time post the course completion for you to play around with and complete the assignment. So the assignment will also involve giving you a VCF file, a clinical information sheet associated with it, and a Google form in which you can submit your inputs after analyzing the data. So if you've not been able to do the hands-on exercise during the classwork, it's okay. We will be giving you the same exercise as an assignment, and you will be needed to complete the assignment and submit it to us for in order to get the certificate of attendance for this course. So, in this particular case, I will now give you the answer for this, and which is that the primary finding for this case that we saw here was a pathogenic variant in the gene LDLR, which is linked to familial hypercholesteremia. So, the course of action that the clinician can take here is LDL cholesterol can be monitored using high intensity statins, monitoring lipids regularly, assessing cardiovascular risk early, encouraging heart healthy lifestyle changes, and doing a genetic counseling for the family. Incidental finding for this patient is a pathogenic variation in the BRCA1 gene, which is linked to familial breast and ovarian cancer syndrome. So these are the two questions that almost everyone in the submissions have answered pretty much correctly. That yes, the primary finding is having familial hypercholesteremia. The incidental finding is yes, having a pathogenic variation in the BRCA1 gene, which is linked to familial breast and ovarian cancer. And by extension of this, yes, the patient is also a carrier for Fanconi anemia, because Fanconi anemia is an autosomal recessive condition. And the corrective action that can be done here for this patient is, or the preventive action in fact, is enhanced cancer surveillance and testing the family, since the disorder is autosomal dominant. And the pharmacogenomics finding for this case, which is something that a lot of you have also caught in the assignment, but some of you have missed, is a variant in the gene SLC01B1, which is linked to an increased risk of toxicity to some commonly used statin drugs. So now that the doctor has this report, the clinical decision would be to choose lower risk statins, adjusting the dosing for these particular drugs, or monitoring for muscle toxicity. Now that we know that the patient has this variation that leads to an increased risk of toxicity to statins. And statins is something that is important to be given to this patient to lower their cholesterol levels. So, this was the exercise for us today, and you can see through this example that one single report that had only a few handful variants coming from a whole genome sequencing test was able to give a lot more answers that you could have expected for this patient. And this is where the power of using such an unbiased and powerful tool like whole genome sequencing holds. And for a very for the assignment, then you can use this exact same approach into understanding what is there as clinical symptoms, and then using the VCF file to interpret results using the clinical interpretation of those variations. So you can see now that WGS does not really reveal a lot of information that is tough to understand. It actually gives a much more clearer picture for a patient in terms of treatment, management, and moving further along on the lines of diagnosis, not only for the primary condition, but also for the incidental thing that we have discovered for this patient, for example. So again, for those who have not yet been able to try out the hands-on exercise, do not worry. We will be giving you an assignment for this, which you can try out at your leisure time and then submit it later on to us in order to avail the certificates. So with this, I think let us now move on to the next session and the last session for this course today, which is the panel discussion. And I will ask Ramya now to take it over. So thank you everyone, and let's move on to the panel discussion.
So, hello everyone. Welcome to probably the most awaited section, the panel discussion. So before we begin it, I would like to welcome our members, Dr. Vinod Skaria. So, Dr. Vinod Skaria is a globally recognized leader in genomics and bioinformatics with over 300 scientific publications, currently serving as the Chief Data Officer at Karkinos Healthcare, Bangalore. He is also an adjunct professor at IIT Kanpur and a distinguished visitor at Ashoka University. A clinician turned computational biologist, Dr. Skaria has led pioneering efforts in rare disease genomics, population scale sequencing, COVID 19 genomic surveillance, and open data science in India. He co founded Guardian, India's largest rare disease genomics network, along with some of India's large scale genome sequencing projects like Indigen and COVID-Seq. He continues to shape the landscape of precision medicine through his research, mentorship, and policy engagement. Our next speaker is Dr. Sridhar Subbu. Dr. Sridhar is a widely respected genomics researcher and currently serves as the Chief Diagnostics and Research Officer and Lab Director at Karkinos Healthcare, Navi Mumbai. He is best known for leading India's first human genome sequencing project and scaling it to the country's first 1,000 genome initiative, mapping India's ethnic diversity. Dr. Sridhar has played a pivotal role in advancing clinical genomics in India through his leadership of large scale efforts such as Guardian, one of India's largest precision medicine networks for rare diseases. A pioneer in functional genomics and zebrafish disease models, his team has also been at the forefront of genomic surveillance during the COVID-19 pandemic, including the first global field validation of the COVID-Seq assay. With over 150 peer-reviewed publications, Dr. Sridhar's work has shaped national and international genomic science from population genomics to translational diagnostics. So, welcome to the stage. I would like to call them on stage. So, I would like to direct my first question to Dr. Sridhar. A few years from now, what your opinion would be about the ethical considerations of not doing a WGS for a patient who can clearly benefit from it?
Yeah, thank you, Ramya, and greetings to everybody here in the talk. Thank you for the invitation. Now, coming back to the question, what are the ethical consideration of not doing a whole genome sequencing in a few years from now, when we know that patients directly benefit from it? That's the question. I think just like the standard of care today, if somebody had a chest pain for a persistent long time, okay, you dial your emergency number, call the ambulance, and take them to a cardiologist right away. So that has become the standard of care. Or the person is sweating unusually and has pain, you do that. So similarly, I think whole genome sequencing will very soon become the standard of care. And today we saw that during the talk, and there are multiple scores of examples already in place where we know that genome sequencing benefits patients in clinical settings. So not doing WGS would not be prudent. I think most clinicians and most individuals, I think, as would want to have their genome sequenced because it provides you with evidence that are clinically actionable. I think it will become almost unethical not to use that evidence when it is available for clinical practice. It's just a matter of time. I think already we are seeing the tractions on ground at not only in well-established clinical settings, but also individual clinicians are taking proactive steps to understand this new bit of genomic medicine and putting it into practice. So I think that question of not using it probably would not arise in a few years from now. It's going to become the mainstream, is my predictions looking through the crystal ball. Yeah, over to you, Ramya.
That's a really wonderful insight, sir. I really love the way you put into perspective of how WGS would be considered in future as well as a part of how it is now. So my next question would be to Dr. Vinod. If every patient carried their genome in their digital health record, what clinical decisions would immediately change tomorrow morning?
The one clinical decision that would change immediately is, of course, what drugs to give and what not to give and what dose to give. This is what we call as pharmacogenomics. Currently, there is evidence for a wide variety of drugs. There are already guidelines for many of these drugs in professional guidelines. But unfortunately, for lack of availability and accessibility of test, which comes in quickly before the drug is administered, clinicians do not practice this widely. But given that you have a whole genome sequencing, that would necessarily mean that you have the pharmacogenomic map of yourself at any point in time and also updated to the current guidelines at any point in time. So that means that you've practically done all your pharmacogenomic tests and that the data is with you. And this, I think, will significantly change the way we practice medicine. And just to keep examples, approximately 60% of Indians would have a pharmacogenomic marker for very commonly used antiplatelet drugs like clopidogrel or warfarin. At least 60% of them would require a dosage modification for statins. So put together, on an average, every individual has approximately 8 clinically actionable pharmacogenomic variants. So I think this is number one that is going to be changing tomorrow. Second is, of course, a subset of individuals who would have an underlying genetic cause for otherwise common disorders would significantly benefit from an early diagnosis, because these patients go from pillar to post, spend subsequent years in trying to get to a diagnosis. And today that is possible to avoid by doing a preemptive whole genome sequencing. So I think these two are the things that will change immediately tomorrow if you had a whole genome sequence for every patient.
Beautifully put, Dr. Vinod, and I can see that WGS is already in good hands, and I'm hoping to see a world where WGS is not going to be just an option anymore, but a solution everyone will look at. So coming back to Dr. Sridhar, when you consider manpower, region cost, batching, repeat testing, and other things, is WGS actually cheaper per diagnosis than panel first strategies?
Yes, if you so the current standard that people follow is to do cascade-based testing. That means you go from the simplest test to the most complex test. But if there is an opportunity today, the barrier for adopting WGS largely are twofold. One is, I would say, cost, which today I heard from several of you that is crashing very rapidly. And if it were available at the cost of whole exome, which is already quite popular, then the cost is no more a barrier. The second would be knowledge for the people, the clinical community on how do you implement it. And second, the awareness in the patient group. If all three were to fall in place, okay, you would see that WGS, which is encompasses most of the genetic tests that we do today as cascade testing into one single test. So I can clearly see that that will become the first line, because it benefits right from the time you are born almost to the time that you pass away. So there are direct benefits to doing it rather than doing piecemeal approaches. So I'm convinced that in the last 2 decades that I have been in this field, that WGS is going to become the standard of care in the very near future. I would say in the next 3 to 4 years, I can see that becoming the standard of care in many clinics world over. So yes, it will become the test to go after.
You are completely right, sir. As we say, boom to tomb. So I feel like WGS might be the wisest choice. Now to Dr. Vinod. Are our doctors ready for a world where the genome tells us the diagnosis first and the clinical exam becomes the supporting evidence? And there is a follow up question after this. What would be the role of reverse phenotyping going forward?
Thank you, Ramya, for that very controversial question. Well, all clinicians in modern medicine are actually taught to evaluate the patient, and a patient, by definition, is anybody who has signs and symptoms. Now, there's nothing in modern medicine except for community medicine which teaches you how to examine an individual or how to study an individual who does not have symptoms and signs. And in fact, preventive and social medicine or community medicine is the only specialty or subspecialty that teaches on how to prevent diseases in the first place. Now, essentially, we are quickly moving toward an era where a whole genome sequence can actually tell you a diagnosis even before the onset of signs and symptoms. And that is essentially the principle of newborn screening. Newborn screening currently is a biochemical array of tests, but given the large coverage that a whole genome sequencing can offer, that quickly would mean that a wide variety of conditions which are undiagnosable today on standard clinical or biochemical test can quickly be diagnosed in a newborn child, and increasingly, many of these conditions are becoming treatable. So the paradigm largely would shift from a proactive approach, or rather a reactive approach, where a patient comes to the clinic and then, of course, considerable amount of time, energy, and resources are spent on the patient to arrive at a diagnosis, to preemptively diagnose an individual for genetic diseases, only for genetic diseases, with the idea that a genome would provide insights into what the individual actually has. And in fact, today there is literature to support this evidence. And if you have gone through the recent paper which came from the Giesinger Health MyCode project, which sequenced around 400,000 individuals, what they show is that just genetic sequencing could double the diagnostic yield of patients who have been in a hospital system receiving care, from 3% to almost 6.5%. And what they also show very interestingly in the paper is that if you can go back to the EHR records, or if you can go back and do reverse phenotyping, essentially look for the clinical phenotypes that can now match what the patient has, that indeed matches a significant proportion of patients. Now, that would necessarily mean that there are already patients around us who have a genetic disease, but for want of the right test, they're not being diagnosed, and therefore they lose considerable amount of time, energy, resources, and of course money before they can get to a diagnosis. And unfortunately, today, a significant of these number of diseases are currently treatable, and an early diagnosis can actually afford them the right treatment at the right time.
So brilliantly said, sir. So it looks like we will be seeing a lot of changes going forward. I think we have influenced our fellow audience as well, and hopefully we have given them, if not a very broad perspective, at least some amount of change of how WGS should be considered as a tier 1 test. So we can now open the stage to our audience. Audience, if you have any questions, due to constraints of time, we may be able to take a very few questions, but okay, so I can probably coordinate on this. So there is a question from Vrishali Patil. My question is for Dr. Vinod. I am a researcher conducting epidemiological analysis of SARS-CoV-2. What are the limitations or challenges associated with WGS for complex samples like urine and wastewater?
Yes, so Vishali, I think you're asking the question about whole genome sequencing of pathogens compared to the whole genome sequencing of humans that we have been discussing. But having said that, wastewater or environmental samples come with the complexity of microorganisms which could be pathogenic, teeming along with a larger proportion of microbes which do not cause disease, or what we call as environmental microbes. Now, fishing out the right candidates of or the pathogen genetic material from a vast number of non-pathogenic organisms or commensal organisms can be really, really challenging. And to add to this, the environmental samples are typically for pathogens very degraded and of smaller fragment size and therefore sequencing them also becomes quite very difficult. I hope I answered your question.
Well said, sir. We'll see if there are any more questions. Yes, so for incidental finding, if we ask whether they want to know incidental finding and they say no, in that case, do we start a treatment plan for the incidental finding, or how do we go about this is the question.
I think I can take that question. So all decisions, whether the patient or individual wants to know about a condition or whether an individual wants to treat a particular condition, is by definition the patient's own decisions. And that's what we call as patient autonomy. So all of this would entirely depend upon the patient wanting to know something and wanting to or not wanting to act upon that. There is no way anybody else, including clinicians or even for that matter, the government, can force an individual to either reveal an information or be able to treat a condition.
So, do we make it mandatory for everyone to undergo genetic testing in India, just like how screening or medical checkups are mandatory for us, or mandatory in US or other abroad countries? That is the question.
Let me try and answer that question. It's again a little bit controversial in the way the question has been stated, but nevertheless, I'll give it a shot at it. So, you, like Vinod just finished, you cannot impose upon a patient to do a test or not do a test, especially if there are the guardrails are not in place. Okay, because all of these tests have to have their legal as well as regulatory guardrails in place. Some countries have them very nicely. You cannot use genetics to discriminate people. You cannot use genetic information to deny them insurance care or socially outcast them. All of these are guardrails and legal regulations that need have been put in place. So as long as they are there, we could encourage people to undergo genetic testing, because the benefits of doing genetic testing outweigh not doing it today. Okay, be it right from newborn babies to all the way to old age people. I think clearly there is enough evidence to today say that there are benefits, heavily, lots of benefits compared to the downsides. But again, I'm coming back to the question: you cannot make it mandatory because you are querying somebody's genetic makeup, unless you have the regulatory and laws or legal guardrails in place. That's where I would like to stop. Over to you.
Really well said, sir. Even though it was a controversial question, I think you answered it in quite good detail. So, there is one question asking, MLPA is still needed because WGS will miss out large deletions and duplications. Do you agree?
Vinod, you want to take that?
I think I will take that question.
Yeah.
MLPA, the variants detected by MLPA are not something that WGS misses. So WGS, in terms of detection, the deletions and copy number variations and duplications are actually found at very different resolutions compared to a standard MLPA. So very large deletions that are typically found by karyotyping is something that is detected very well by a WGS. For smaller ones for which we run to an MLPA, something that is detected by a WGS. And for the extremely smaller ones that only span a few exons, for example, are also something that are detected by a WGS. So no, if you are doing a WGS, that does not mean that you need to run to an orthogonal method to validate your CNV. You do not need to you don't need to do an MLPA again, because WGS will not miss out these large deletions and duplications.
I think we have time for just maybe one or two more questions. So this is a question that says, could you comment on the idea that whole genome sequencing still faces challenges in terms of tertiary data analysis, clinical reporting and cost, making clinical exome sequencing a more practical first-line diagnostic approach at this stage?
Thanks for that question. And in fact, it is quite the opposite. In fact, the pipelines for whole genome sequencing are now quite well standardized and quite well accessible, and of course, much faster in many ways than whole exome sequencing. So, to put into perspective, today it is possible to actually do a whole genome sequencing much faster than doing a whole exome sequencing, and more importantly, provide much more information that can guide therapy of the individuals, like, for example, pharmacogenomics, which, for example, includes classification of the disease phenotype based on haplotypes. For example, look at HLA types, which can aid transplantation, look at rare blood groups, which can aid in transfusion. And therefore, at any point of time, I don't think whole genome sequencing is limited in any aspect, either by the pipelines, the coverage of information, or the speed. And of course, the cost has been dwindling very rapidly, and we hopefully would have whole exome sequencing cost very similar to that we have for whole exome sequencing.
Very nice way of putting it across, sir. So maybe we have time for one more question. So I am a leading clinical excellence and working on a clinical AI front. I wanted to know what are the major challenges that can be met by AI interpretation of the WGS report.
Okay, I think Ramya, you and I both can take up this question. So, one thing that is most fearful for a lot of people handling a WGS report is thinking that it comes with a vast amount of data, and this is not something that doctors typically want to look at. So, using computational methods, we are basically filtering out that data to make sure that only meaningful information remains in the WGS report. And AI is actually at a very central position for all of this now, given that we have a lot of sophisticated algorithms, generative AI, LLMs coming in that can help us not only understand the variant data that is coming up, but also sift through a lot of literature that is present for different variants, genes, and diseases to help us interpret a report better. So, yes, one of the challenges for me, personally speaking, that AI can now solve is the variant interpretation challenge, which is something that a lot of us are working on fixing. But the more hands, the better in this situation, because a lot of different approaches can be used to solve this problem. And Ramya, you can also add on probably how AI will help you in uh, easing out your workflow.
I mean, I think I can give a little bit of my perspective. I believe that AI, if utilized in the right way, would be very, very beneficial in the interpretation of the WGS report. So, at this point in time, I don't think you can be using AI without having like a manual check over it, is what I believe, because ultimately it's very patient sensitive data, and we have a lot of responsibility to deliver the right diagnosis and the right interpretation to the patient. So you can of course use AI like a almost like a Google Maps navigation sort of a tool to navigate through your attributes, maybe your classification and how you're interpreting it. But relying on it entirely is a different story altogether. That would be my take on it. So I think due to shortage of time, we may not be able to answer any questions live right now, but we will definitely get back to each and every one of your questions. I would like to thank all the members of the panel for their patient discussion and answering all the questions with so much of interest, so much of passion. And thank you very much. I would now hand over the stage to our host, Harish. Harish, over to you.
Sridhar sir, thanks a lot, Vinod sir, for guiding us through a lot of aspects of sequencing. Bani, thanks a lot for all your valuable insights. Bani and Ramya, you've been amazing throughout the course. Thanks a lot for teaching us so many new things. This is really wonderful. So, what we realized is what we truly realized is that uh, while we are promoting WGS for all, while we are preaching and sharing a lot of insights on what we are doing and the benefits of WGS, most of us will be curious to do our own sequencing to understand ourselves better. Now is the time for you to do a WGS and understand yourself better. So we are sharing a link out here. The QR code is visible on the screen along with the links. You can use that to register a whole genome sequencing test for yourself. Our team will get in contact with you shortly, and this is offered as an extremely lower price, in a never before price. As we say, the cost of sequencing is becoming exponentially lower. Open the link and explore to see the price for yourself. It is an extremely low price for all of you to just get a WGS done for yourself. Hope the knowledge benefited all of you. Hope the WGS testing also benefits all of you. Thanks a lot for being a part of today's wonderful session.
Thank you, Harish. Thank you, Ramya, and thank you, Bani, for the wonderful session.
Thank you, sir.